All right. Good evening, everybody. Thank you so much for being here. My name is Justice Ehlers. I want to welcome you all to the Coal Eye Imaging Summit. We're going to go ahead and get started. We're really excited to have a fantastic faculty here. Hopefully have a great night of talks in store for all of you. These are our learning objectives, which I'm not going to read. You guys, I think, have those already. We also partnered, want to thank our iVista team for making this happen and getting everything organized for us, as well as through our sponsors and the grant support from Apellis, Genentech, Topcon, Regeneron, and Zeiss. And then our exhibitors here. I know many of you were already out for dinner and for drinks. Please make sure you visit our sponsors. We'll have one other break this evening. And then for your CME credit, please be sure to scan the QR code. There's the pre-test and post-test questions, and then the certificate as well. And with that, we will get things started. Our first speaker is Amani Fauzi from Northwestern University, who's going to talk about OCTA and when it's useful in clinic. Amani.
Thank you very much, Justice, and thank you everyone for coming. So today I was going to give a primer about OCT angio and how we use it in the clinic and which situation and where it's useful. And so I'll go over some basics, some artifacts you need to be aware of if you're starting in OCT angiography, and how OCTA differs from fluorescein angiography, and how the cases where it's really helpful in practice. So just to think about, in general, how OCT angiography works, you're taking two pictures of a river, assuming that's a blood vessel, and then you subtract everything that's not moving and only show what's moving. Those two pictures are 3 milliseconds apart, so everything that moved in those 3 milliseconds shows up, everything that did not move disappears. And compared to OCT, where you get a dense raster, each scan is done once and then projected en face. In OCTA, you get 2 scans in each location, and you subtract what's not moving, and you only show what's moving, and then you project it, and it's the angiogram. The nice thing about OCT angiography is that you have all the information in one scan. So you have the flow, but you can also project the structure on top, and then you could see where the flow is in relationship to the OCT structures, where it's located, is it abnormal. And I find that these cross-sectional sections with flow overlay are the most useful in clinic when I'm having trouble figuring out if it's an artifact or if it's real or if there's motion or if this is projection. This is really the most important view for me in the clinic. And so if it's 3 milliseconds apart and something's moving really slowly, like this guy who's floating on his floaties, then you basically disappear between the, if you basically do the subtraction, these kinds of things disappear. So microaneurysms on a OCT angiogram, you could see anywhere from 40–60% of the microaneurysms, so not all of them will be visible. Polypoidals and the polyps themselves, the flow is so slow and turbulent, sometimes they don't show up. And then you can see that capillaries come and go in an angiogram. So if you get a series of angiograms on a patient, sometimes you'll see capillaries come and go. These are probably capillaries with very slow flow. And if you are really starting out in OCTA, I recommend this paper or a similar paper that talks about the artifacts, because I think that's the really Achilles heel of these machines, is the artifacts, and they can confuse you. You could see flow where it's not, and I encourage you to read one of those. So this is an example of one of those artifacts, and so this here looks almost like a branch retinal artery occlusion or branch retinal vein occlusion. All the vessels on the top half are invisible, but if you look at that cross-sectional view, it tells you what happened. So here you don't even see the OCT signal in that area, so that tells you there's something blocking the signal from getting to the retina, not just the flow, even the OCT signal. So this is a big floater, actually, and not a blood vessel problem at all. And then when you see these kilting artifacts, it tells you that the patient's moving. You really have to be careful with these angiograms that have all this motion artifact, because they usually have other artifacts as well, and the signal strength is very low. So these are usually unreliable. If you're doing a study and comparing across time, these sort of similar scans like this, we throw them out. You can't really get good information out of them. So how do I use it in clinic? I think in AMD and when I'm trying to rule out macular neovascularization in any type of disease, so if it's inflammatory, CNV, multifocal choroiditis, if I have a patient with a very thin separation of the RPE and Brooks membrane double layer sign, if there's subretinal hyperreflective material, I'm trying to figure out if it's a CNV or vitelliform. These situations, I do not need a fluorescein angiogram. I can just turn on my flow signal and I've got the answer. So I think in AMD now, I can't remember the last time I ordered a fluorescein, probably 5 or more years. So for AMD, I don't use fluorescein anymore. So the slab options for looking at the neovascularization are usually outer retinal slabs, so in areas where there shouldn't be flow. So once you see flow in these slabs, it means it's abnormal flow. So in some machines, it's just the outer retina, and other machines includes the choroid capillaris as well. So ORC slab versus outer retinal slab, depending on what manufacturer you're using. So here's an example of a patient where I was convinced there was a CNV, there's subretinal fluid, shrim, a PED that looks fibrovascular. But the OCTA shows this smudge. I was expecting these beautiful networks of vessels. It looks like a smudge. So then you go back to the machine and you try to figure out what happened. Sometimes the projection removal software is so powerful that it removes real flow. So you can manipulate the scan a little bit, and lo and behold, you can see the flow signal. We use the choroid capillaris slab and just use that to reveal the flow. And then if you look at the cross-sectional data, you'll see that there's flow between the RPE and Brooks membrane, not on top of the RPE and not somewhere else. It's really between the RPE and Brooks membrane where you would expect the neovascularization to be. So that's very important to rule out that it's artifact. So here's an example of a RAP lesion. So the fluorescein shows you that bright hyperfluorescence next to the vessel, and you have this outer retinal sort of circular lesion. You turn on the flow, and the flow is inside the blood vessel, inside the circular lesion, not on the hyperreflective part of it. So that's very reassuring. So here's another example that's a little more tricky. You have a large drusenoid PED, and then there's this lesion there that has flow. So is this a RAP lesion? There's no fluid there, there's no intraretinal leakage or anything, but the clue here is in the RPE. So as you could see there, there's like 1 million flow signals on the RPE. And these are all projection artifacts from the blood vessels above them. So this is a very artifactual scan, and at the same time, this is an artifact too. This is just a hyperreflective foci with pseudoflow. So if you look at the RPE and you see this continuous flow on the RPE, that tells you this is a flow projection artifact. And you can't trust most of the flow in the scan, especially if it's in a hyperreflective spot like this. So the next important thing that we need to look at the OCTA for is this type of lesion, where you have a neovascular lesion on the slab there, on the projected slab, and you look for the flow and you see this shallow elevation of the RPE with flow between the RPE and Brooks membrane. So this is a non-exudative CNV. When there's no flow, there's no fluid, you want to watch these carefully. So these lesions can stay quiet for a very long time, but have a risk of exudation at some point. So if you have drusen and this type of lesion, I would follow them maybe every 3-4 months and give them an Amsler grid, because the risk is anywhere from 6 to 26% within a year for conversion to exudative CNV. So we warn those patients, give them an Amsler grid and monitor them closely. I suppose if you had a home OCT, these would be the really high-yield patient to send home with a device like that. And it was Phil Rosenfeld that showed us these lesions. So if you look here, these are very shallow sort of elevations, these double layer signs, and the flow is between the RPE and Brooks membrane. In the past, you used to need an ICG angiography to reveal these lesions, but now with OCTA, we could see them. And if you start to look at your OCTs in the drusen patients carefully, I'm seeing more and more of these sort of hiding under the RPE. The next important lesion, too, is when you have a patient like this with something that looks like PIC, multifocal, and you're wondering, should this patient receive steroids alone, or do they also have a neovascularization within that, and do we need to give them anti-VEGF? And you can see here there's 3 or 4 lesions, and they're all leaking on fluorescein. Hard to tell which one of them has neovascularization. So then you turn on the OCTA, and you look for flow signal between the RPE and Bruch's membrane, and only one of those lesions had flow. You know, the sticklers, the uveitis, sticklers might say it doesn't matter. They respond to anti-VEGF and to steroids, but you know, you want to know if you want to know. This is a good way to know, and fluorescein really isn't as revealing in these cases. So in diabetic retinopathy, it's a different story. You know, we do a lot of research in diabetic retinopathy. We order a lot of OCTA in diabetic retinopathy, but really we haven't gotten to the stage where we could forget about fluorescein angiography in diabetes yet. So there's the problem of the peripheral retina. So no matter how wide your swept source OCT angiography is, you still don't get that very peripheral retina. You can miss lesions, non-perfusion in the periphery. On the other hand, the OCTA does a lot better at revealing non-perfusion because it's not covered by leakage. We don't see leakage in OCT angiography. So if there's non-perfusion, it's much easier to detect. But you don't see the periphery. So you really have to use your fluorescein angiogram. So I still use a lot of fluorescein in diabetic patients. And if you're trying to treat a microaneurysm, and you're looking for leaky microaneurysms or large microaneurysms, it's much easier to see them on fluorescein angiography. And you really, even with swept source, you know, how far you get with swept sources is variable, but you really can't get to that peripheral, predominant peripheral lesions and non-perfusion all the way to the aura. Still not there. But here's an example comparing a fluorescein angiogram and an OCT angiogram. And the really hard to see the non-perfusion here on fluorescein, but as you can see with the OCTA, with the swept source, you could see deep capillary non-perfusion and enlargement of the FAZ, areas of non-perfusion that are really harder to see on fluorescein. With more sort of, when you get more images, and especially if you're looking for neovascularization, it's really nice to have sort of the en face view, but also to look at the cross-sectional scans. You could move the slab up into the vitreous, and you could see that, you know, these are large neovascular lesions here in the vitreous, because you know you could basically slide your slabs up and down, but you can also look at the cross-section. You'll see the flow here on the back of the vitreous. So that tells you this is neovascularization elsewhere. So here's an example of a patient where it was a little more tricky. So you see here areas that look like neovascularization and areas that don't. And on the OCT angiogram, everything is sort of more clearer, I would say, than on the fluorescein. On the OCT angiography, it's a lot clearer. The extent of neovascularization is just beautiful. You can see neovascularization everywhere. But there's 2 lesions that look almost the same. One is more leaky than the other. You could see here one of them is neovascularization on the top, at the back of the hyaloid, and the other one is just ERMA with no neovascularization at all and just thinning of the retina. So it really helps us decipher these lesions. And finally, for the last few minutes, I'll tell you about some important pitfalls and how it's important for the photographer. This is sort of, you rely a lot on your photographer, taking good imaging, focusing, making sure the patient, they blink and take out the sort of dry eye and make sure they get the best images out of the patient up front, because you can't really improve signal strength when it's not there. So here's an example of a patient who was imaged on the same session, in the same day, with, you know, minutes apart, and the scans look bluer and bluer. So does he have, is he basically asphyxiating while he's sitting in the chair? So this is a really clever paper that was written by Brandon, and all they did is defocus the image. They just put a -1 in front of the patient sitting in the chair, and they could simulate ischemia, progressive ischemia, just by defocusing. So if the patient just sits back a tiny bit on the on the camera, they could basically simulate this. So here's another example of a patient, again, separated by a few minutes, and looks like their FAZ is enlarging. This is a very beautiful paper from Korea. And basically, the higher signal strength scan has the bigger FAZ, because when you have lower signal strength, any dot is basically taken as real flow. Any noise becomes flow. So you can really change the size of the FAZ. You could even change the non-perfusion area by changing the signal strength. And this paper showed that until you get to signal strength of 9 or 10, like a perfect signal strength, every 1 point change in signal strength leads to a significant change in non-perfusion and foveal avascular zone. So you really have to be careful when you're seeing the same patient over time to look at that signal quality, image quality, before you judge it. And then large axial length can affect the scaling of the images of the foveal avascular zone, so that's why you need to be careful with high myopes or high hyperopes. And so to overcome these pitfalls, you really have to educate your photographer. They really can make or break your images. If you get poor quality images all the time, you'll hate your machine and you'll throw it out, when it's really just educating the photographers about focusing, spending a little bit more time with the patient to get good images. And if the signal strength is less than 6, usually we just ignore those scans, because you can see a lot more artifacts and see things that aren't there. And we usually adjust for signal strength when we do clinical trials and clinical studies. Even astigmatism can affect the vessel density, so you really have to be careful. And quality of the images up front is key, so spend some time teaching your photographer and learn to use that cross-sectional view with flow overlay. And so in AMD, I hardly ever get an FA anymore. I can't remember the last time I got it, and now with the OCT criteria for polyps, I find I'm not getting ICG either. So we're relying on the OCT and the OCT angiogram to make the diagnosis and follow these patients, because really, even though we keep writing about it, there's no biomarker for activity on OCT angiography. We can tell everything from OCT, and where I still need fluorescein is diabetes all the time, and maybe after I hear Sumit's talk, I'll stop ordering it in uveitis, but we still get it for vasculitis and peripheral lesions and things like that. And I thank you for your attention.
Thanks, Amani. We'll have time for Q&A. Our next speaker is Vas Sada, who's going to be talking about the clinical value of high-resolution OCT in AMD. Vas.
Thanks very much, Justice. I really appreciate the opportunity to participate in this great symposium. So these are my disclosures. It's relevant right here. But I just first want to clarify what I'm talking about when I talk about high-resolution OCT, because I could be talking about one of two things, because OCT has multiple dimensions in which the resolution could be improved. So I'm going to start first with transverse, but that's actually not really the focus of my talk. But there are ways to improve the transverse resolution. We're in this era of very fast scanning OCT devices. A lot of them are used for OCT angiography. Actually, in my own opinion, one of the greatest benefits of OCT angiography is introduced us to the concept of what we call isotropic scanning, where we have the same number of A scans and B scans. And that really allows us, I think, to make very interesting observations using en-face viewing of OCTs. But if you want to improve the transverse resolution further, you actually have to make the laser spot falling on the retina smaller, and we can only do that using adaptive optics, which obviously can be quite expensive. But if you're able to deploy that, then you're actually able to resolve all those different bands that we're interested in studying are actually broken down into their component cells, so we can actually visualize the photoreceptors. And we've been using it in our own institution to study a variety of lesions, including AMD-related deposits. But that's actually not my focus. My focus is really to talk about improving axial resolution, which with our typical OCT devices are 6 to 7 microns historically. Of course, remember when we started with time domain OCT, it was down at 10 microns or 10 to 12 microns. So that was also already a doubling. But we're talking about going further. This used to be only possible with expensive systems, but now there are much more reasonable pre-commercial sort of systems, and we're expecting that this is going to be broadly commercially available in the near future. But again, the reason that improving axial resolution matters, of course, is then you can actually separate bands that may be very close together, which would otherwise be merged together if you're not able to have that type of resolution. So it's an example of comparing 3 micron resolution versus 7 micron resolution OCT with regards to visualization of the outer retina. But I'll show you maybe this example, which kind of compares the holy grail. If you merge adaptive optics with higher axial resolution, then you actually can start to see some of the cellular detail. And we actually are starting to get closer to histology, but you can see even with high axial resolution OCT that some of that information starts to be discernible. I still don't think it's histology. Some people say it's histology, but I think that they're interesting optical artifacts. But there are some advantages, right? So I'm going to highlight how we found this to be clinically beneficial, and I'm going to start with something that seems quite mundane, which is looking at bright spots in the retina, and many of them, Dr. Fauzi beautifully showed how we can visualize flow using OCT angiography. But notice the retinal capillaries, when you improve the axial resolution, have this very interesting shape. Hopefully everyone can appear to glean that sort of bilobed, sort of we call snowman or hourglass kind of shape related to the flow. I'm going to bring up why that's valuable in a moment. But one of the challenges that high-res OCT, of course, has introduced is, we just got done sort of understanding what all of these outer retinal bands we think are, but now we see many, many more bands. In fact, more bands than are cells possible there. And so, I pointed a question mark to what's that band called. Recently, Christine Curcio published a suggestion for how to name these. She used kind of a numerical system where you might break the EZ into multiple bands, the RPE into multiple bands, like numerically. But the answer is we're still trying to figure that out. You can even see an example of the middle limiting membrane, which is the synaptic layer between the photoreceptors and the bipolar cells that's revealed. But I wanted to sort of give at least one a really solid clinical example and focus on AMD just in the interest of time as an area where we found this to be of particular benefit. And so we and others, Cindy Toth at Duke and several others have really been very interested in looking at biomarkers that we think might highlight patients with AMD, intermediate AMD, who we need to watch more carefully at risk for progression. And we've identified these features like these dark spots in drusen or hyperreflective foci, which are a really hot topic these days in retina. And we've shown in multiple different studies, this is just one of many, where repeatedly these factors turn out to be important for increasing the risk for progression to late AMD. But one of the things I want to highlight is that are all the bright dots in the retina hyperreflective foci? I already highlighted that some of them are going to be capillaries. Now, we hope that the ones that aren't capillaries are brighter, but I will tell you they're not always brighter. So it can be a challenge to distinguish these. And this is where high-res OCT can really play a big role, because there's really no doubt now, because you see the capillaries have that very unique bilobed sort of appearance, which can be helpful for distinguishing them. So here's just an example where you see the little yellow arrows are ones where you see bilobed guys, which are the capillaries, and the white arrows point to ones that don't have that bilobe structure that are hyperreflective foci. And if I show you the comparison with conventional, again, it's blown up, so it looks like it's blurry, but it's actually a good quality OCT scan, but can be very difficult to distinguish for many patients. Now, there's other risk factors, of course, that have been studied and identified, like subretinal drusenoid deposits, and they can go through, we don't really use this staging system anymore, but really I wanted to put this up to say that very early stage lesions can be difficult to detect, especially you can imagine if it's, if you don't have this kind of resolution, it's very difficult to actually detect the very early stage lesions that I'm highlighting in this comparison between high-res and conventional OCT. There are other risk factors like that we've published on, like having a lot of drusen. And of course, when you have these large drusen, we can sometimes have, my colleague at UCI, David Schaff, pointed out that you can have fluid accumulations that appear at the sort of the crevice between two drusen. And sometimes you're wondering Is that actually evidence of neovascularization? But sometimes we can be confused as to what that is, and this is where having the higher resolution, I think, can be quite valuable. We've spent a lot of time on defining atrophy in OCT. We have this definition for C. aurora with hypertransmission of a certain size, having evidence of RPE loss, and evidence of photoreceptor degeneration as well. And of course, you can go one step below that, where lesions don't quite meet that threshold, we call iRORA. And this turns out to be somewhat valuable because you can look for conversion from this precursor state of iRORA to C. aurora, and we've shown that in post-hoc analyses we can see these conversions. But we also know when you have multiple reading centers look and try to grade iRORA, it's not easy. In fact, I was hearing that complaint earlier today at another meeting. People said, I can't identify aurora. And we know that it can be difficult. And so the question is, can high-res OCT help? And one of the things I want to highlight is you can really appreciate with high-res OCT the true thinness of Bruch's membrane. Okay? And I think you can really appreciate the difference in actually that measurement. But I want to say that when you're trying to evaluate the outer retinal band, you can see where that last RPE cell is hanging on for dear life before you end up with none. And this is where it's been strikingly different for us, whether it's also evaluating some hyperreflective drusen cores and like. I also want to highlight this feature of outer retinal tubulation, which again is more easy to distinguish with high-res OCT. But what I wanted to highlight is that we've actually studied this, and especially if you're interested in quantifying these outer retinal bands and abnormalities, we've shown in this publication that there's a big difference. I think you can easily appreciate the difference between standard resolution and high-res for delineating the outer retinal bands. And for quantification, this seems to make a very big difference. I mentioned about outer retinal tubules, which we can see in many of these lesions. I actually look at these as areas where there's no RPE, and the photoreceptors, I say, are huddled for dear life, huddling together to sort of survive. Sometimes you can have a little RPE cell in the lumen that you can visualize using high-quality OCT. But as I said, you can see the ability to resolve these lesions much more clearly and definitively with high-res OCT. And they're not unimportant, right? We had previously published that if you have a GA lesion that has outer retinal tubulations, they tend to grow slower. And I know that Kensington Escher was in the audience, but he led this nice study using data from Derby and Oaks, where again, it was interesting that these outer retinal tubulations have clinical impact. In this case, not only slower growth, but actually lost less vision. So it's not a trivial thing to recognize these findings. Last thing, the last minute, I'll talk about neovascular AMD. You can, sometimes one of the questions that comes up, Amani talked about using OCTA, but she talked about some of the challenges of interpreting OCTA, and you wonder, are these RP elevations vascularized? And because some of them may just be thick basal laminar deposit. They may not be vascularized like in this example. And we know that it's important to recognize because these patients are at higher risk for converting to exudation. Sometimes when it's very thin, we say it's just basal laminar deposit, or we call that a thin double layer sign. But can we really be confident whether they're vessels or not? And I just want to say that because you see the additional detail between the RP and photoreceptors, this is an example of a patient where you can recognize the polypoidal lesion in this case much more clearly using high-res OCT. And I think that gives us a lot more confidence, especially when the OCTA is a little bit questionable. And of course, you can study other things like, and again, this is more examples of details in neovascular membranes, but Bruch's membrane breaks as well. We have identified that more breaks can have some prognostic significance. I'm not going to go through that because of lack of time. I just wanted to highlight that Bruch's membrane breaks are much easier to visualize, and you can actually track the path of the vessels into the neovascular membrane, which is pretty interesting. So to summarize, I think there are some real advantages of high-resolution OCT. It is going to be the new standard. I don't really have a lot of doubt going forward in the future of what we expect in terms of imaging for patients, but I think it will be particularly of value in this new era of therapeutics that we've entered into for atrophic AMD. Thanks very much. These are my fellows who really led this project. Thanks very much.
Keep questions to after this next talk, which is just going to be by Dr. Ehlers.
All right, thanks, Sumit. So I'm going to talk a little bit about imaging outcomes in dry AMD, but with a more of a particular focus on how we use it in clinics. These are my financial disclosures. So as we know, we're really in a new frontier in terms of dry AMD therapeutics, particularly here in the US, where we're managing dry AMD in a way that we haven't ever before. We have treatment for geographic atrophy, and being able to personalize that care and decide when to treat people is really important. Imaging is really the staple for how we manage so many different conditions in retina, and that imaging is really key for us as well. In dry AMD, we saw already great examples from both Vas and Amani of where some of our imaging technology can play a role. And so for dry AMD, what are the key outcomes that we look for in clinical management that change the way that we care for the patient who's sitting in front of us? So for me, when I think about it, the key imaging modalities that I may use in dry AMD include fundus autofluorescence, OCT, and then very rarely fluorescein angiography, as Amani alluded to as well. I'm not sure the last time I got one in dry AMD or wet AMD, and combined with OCT angiography. And so what are those outcomes that we're looking for? As a clinician, when we're monitoring these patients who have dry AMD, really what we're trying to understand from the gold standard is, have they progressed to advanced? Have they converted over to neovascular AMD? Have they converted to geographic atrophy? Some of the more emerging things that we may be looking for include things like ellipsoid zone loss or hypertransmission defects that may actually allow us, as new treatments come available, to treat patients earlier. The other question that we have, as we're looking particularly in my hands when I'm deciding whether or not to treat somebody, is, are they changing longitudinally over time? So it's not just did it happen, but is it getting worse? And that includes growth of GA, expansion of ellipsoid loss, or growth of hypertransmission defects. So how do we image for wet AMD conversion? So certainly fluorescein angiography was the historical gold standard for imaging in retinal disease, but it requires, it's invasive, you have to do the intravenous injection of fluorescein. It allows us to see leakage, which is advantageous, non-perfusion, staining, and all that. But there's really been a significant reduction in utilization. I still completely agree with what Amani said. I think it has a really important role for diabetic retinopathy and vein occlusions as well. And although I don't see it, luckily, also in inflammatory eye disease. But when it comes to wet AMD, where would we use it? And we still use it in clinical trials, and that is to really identify whether or not there's signs of any sort of CNV that's present that could change how you're going to manage that patient. But really, that's been supplanted, as we heard already, from really two different modalities from my perspective. One is OCT angiography, which reconstructs the vascular flow patterns. It doesn't give us leakage information, but for me, in terms of identifying CNV, that doesn't really matter. We're able to use structural OCT to see signs of exudation and activity. It matters for me when I'm looking at retinovascular disease, but not from a wet AMD side. And this really has improved significantly. One of the questions I was going to ask Amani is around how often you have to do manual segmentation. When this first came out, I was really excited about it in dry AMD, but there were so many artifacts related to drusen that made it really difficult to use, and that's now improved dramatically with some of the software enhancements. But the other thing that's really the workhorse for what we use is just traditional structural OCT, being able to identify the development of fluid, intraretinal fluid, subretinal fluid, hyperreflective outer retinal and subretinal material, as well as the development of a double layer sign, can all sort of change your trajectory of whether you're starting anti-VEGF therapy or you seeing them back in a month or 2 months instead of 6 months. So what about imaging for GA incidence and progression? So fundus autofluorescence is really the gold standard that we've thought of for identifying GA. It's what's still used as the gold standard in most of our clinical trials. There's different features that we can see that are more at risk for developing geographic atrophy and also for change over time. And it's really a nice teaching tool. When we show patients this is where the areas of atrophy are, we can really connect with them around some of the visual symptoms they're having, particularly in things like focal scotomas, loss of letters as they're reading, and can be used to explain some of the vision loss that may be more subtle atrophy. But this often isn't necessarily widely available. Even in retina practices, you may not have it out in your regional offices, so that can be a challenge. But this is still really often the core of what we use for on-FOS measurements of change over time for GA growth. So for GA incidence, we'll talk more about other modalities to be able to use, but for GA growth, you can use this both quantitative and qualitatively. Machine learning algorithms and automated algorithms for identifying where those boundaries are have become really, really good, and being able to see this over time and understand maybe you're wanting to put somebody in a clinical trial or use one of our current approved therapies for treating these patients. What about OCT and geographic atrophy? And I'm going to spend the rest of the time talking about OCT because honestly, for me in managing dry AMD, this is really the only thing that I feel like you really need if you're sure that it's dry AMD and you're not looking for other things like masquerade syndromes that may actually fundus autofluorescence could be really helpful for. But when we think about outcomes, we heard from Vas some of the things that we may be looking for. There's many features that can kind of alert us to someone who may be more at risk, things like hyperreflective foci, subretinal drusenoid deposits, hyperreflective drusen cores, and complexity that we see in drusen, as Vas alluded to. iRORA, CRORA, and easy loss are all things that as you start to listen to patients' symptoms, if you look more and more at the OCT, you can start to pick out perhaps why it is that they tell you they're getting worse over the last 3 years, but their vision's still 20/20. But if you actually look really carefully at their OCT, you're seeing progressive changes in the outer retina that may explain some of what they're seeing. So how can we actually use OCT for looking for GA incidence? So this is something that, again, there's multiple ways to do it depending on the device that you're using, whether it's using on-FOS OCT or using the near-infrared reflectance patterns. You can actually see relatively clearly where those areas are of hypertransmission to see that GA has developed. And this is going to be a really fast tool, depending on what your imaging review system is, to look at what was it 2-3 years ago to what is it now. Additionally, we're getting better and better segmentation systems. So here is an example here of being able to look at the sub-RPE Brooks membrane compartment where we see the drusen there in sort of this green and then the pink showing the areas of GA. And as we get better automated systems, it's going to be able to pop out at the clinician and also, again, be able to use as a teaching opportunity for our patients. This is another example here where, for me, I really don't use fundus autofluorescence that much to look for GA progression. I use OCT. Both the combination of using either on-FOS or the near-infrared reflectance, you can see there is no doubt that over the course of the last 2 years, this patient has progressed dramatically in the amount of geographic atrophy that's there. You see it both not only in the on-FOS image there, but also in the actual outline of the RPE defect. Last thing I'm going to talk about is imaging for photoreceptor damage and other structural biomarkers that we're using more and more for OCT. The biggest challenge right now is that our commercial systems don't have automated platforms for doing this. So you really have to be looking for it from a qualitative side, but more than likely these tools are going to be available, whether it's as an add-on, where you're using it in some of the new AI technologies that are out there that maybe you upload the OCT, or whether it's embedded within the device review. So one of the first things is hypertransmission defects. And so this is really on the spectrum of what we see in iRORA and CRORA. But the idea is that you can see this even in intermediate AMD. When you start to develop attenuation of the RPE as well as thinning of the outer retina, you have increased transmission of light into the choroid, as you can see here. And that can be observed both on the B scans or as well as in the on-FOS images. And this can be used to really look for areas of high risk for progression. There's been studies by multiple groups showing that when these are at a certain level, they're reproducible, consistent, and also at high risk for CRORA conversion over time. These are some examples here. When we look at the images over to the right, the top is actually the drusen volume map that we can see there, and we see the drusen actually reducing over time, but the disease is actually progressing. So even though the drusen are going away, the disease is getting worse. We can see there in the second row, the areas of hypertransmission becoming more and more definitive over the course of time, and then actually the very clear delineation using software to actually measure those areas of hypertransmission. So right now, this is something that's being looked at potentially by the FDA. The challenge is the FDA for dry AMD does not, or any ophthalmic disorder, allow incidence or development as an approvable endpoint. It really has to be changed over time, which is something that we'd love to see really changed from their perspective to allow us to look at different endpoints for our emerging therapeutics. But what this hypertransmission does for a clinician is you can look at it again, both from the on-FOS side, but also as you're scrolling through. Sometimes, depending on the quality of the image, you may not be able to see it quite as much on the on-FOS images when you're scrolling through and seeing that hypertransmission on the B scan. And this can be measured both manually, or it can be measured now with deep learning algorithms as well, as you can see an example here. What about ellipsoid zone loss? So again, this is a very hot area of discussion, both in terms of new and emerging therapeutics. As one of our most recent drugs that was approved for MACTEL was approved based on an ellipsoid zone change as an endpoint, but also for dry AMD, it's been suggested that we can actually use that now, and a phase 3 trial is currently looking at that. And one of the measures we can use is actually what the height is between the ellipsoid zone and the RPE, and when that's totally gone, being able to look at this over time. So these are some examples here of intermediate AMD. We see the drusen maps in the second column there, and the ellipsoid zone integrity map totally green with no changes in the ellipsoid zone alteration and minimal changes over 2 years. Conversely, here in that third column, now we see ellipsoid zone loss at baseline that dramatically increases associated with GA development over time, and often this will be linked with overall increased symptoms as well. So the reason that I really love OCT for clinical evaluation is you can look at all of these structures. You can look at hypertransmission, you can look at geographic atrophy overall once it gets to that level of severity, but you can look also at photoreceptor damage from ellipsoid zone loss. And these are just different clinical examples over the course of 5 years of the ellipsoid zone integrity changes and the dramatic differences in phenotypes that we can see in this disease, and why when you see somebody who has geographic atrophy, you really want to understand that course and speed of change over time. So in conclusion, there's really a wealth of information that we use as we manage dry AMD, and how we use different imaging may vary based on our offices, our personal preferences, the software that we have on board. But really, as we get better and better software technology, and as we saw with VOS, higher resolution systems is going to continue to be something that we lean on, both in deciding on how to manage these patients, as well as treatment decision making for what therapeutic we should be using as well. I want to acknowledge my team, and I think now we'll go on to any questions and answers for our panel. Thank you very much. So questions for Amani, Boss, or I guess me.
I had a question for Amani, actually. Now that there's a CPT code for OCTA, do you use OCTA for all your patients? Do you just use it for select patients? Because you can still obviously get a lot of information on the OCTA that you would get on an OCT.
Yeah, I'm glad my chairman doesn't think that way, because we get a lot of OCTAs, and sometimes the patient gets OCT and then OCTA, and they sort of keep bouncing around the instruments in our clinic.
Yeah.
But you're right, we only bill for the OCT, and we don't get extra paid for the OCTA. And so I only order it when I really am going to use it. And for most of my research, I just use the non-clinical machine for my research. But for AMD, I find it very helpful to make a decision whether or not I'm going to start treatment. I show the patient, I just educate them, especially if they're sort of parafoveal or something like that. I use it to show them the disease. But yeah, I'm
Which
glad.
system do you use, Amani?
So we have, I mean, I like the OptiView most because I'm most familiar with it, and they've gotten better with the Solix, and I think their projection removal software got better and better over the years. So I'm not familiar with the other machines as much.
Yeah. Adrian, did you have a question?
Yeah, I was going to ask something along those lines. If I'm an OCTA novice and don't have the elegant interpretation, I'm just here willing to invest in an OCTA, what any particular platforms that you think would be the most user-friendly for somebody that didn't have the elegance and expertise that you have?
Wow, that's a big ask, boss.
Shift it to Voss.
Yeah, I don't think that there's any one platform that's easy. I think the reality is that, as Amani pointed out, many of the pitfalls, right? So the biggest challenge for using this in clinical practice is that you have to contend with some of the segmentation errors. You have to spend time to make sure you're not thinking about projection artifact. Now, many of the devices include AI-based enhancement tools, which may or may not make real information disappear. So it actually isn't easy, and so we use it selectively for patients who we think there's value. I mean, I think some of the biggest indications Amani talked about, things like is there neovascularization or not, can be very useful. One thing that I don't think Amani talked about that we find it to be useful is in inflammatory diseases, especially when you're dealing with placoid. Sunil's not here yet, is he? So when he comes in, he'll probably talk about it. But for placoid keratopathies, seeing that, you're obviously the world's expert on sickle cell, Adrian, and so, obviously she's talked about, the retinal quantification monitoring, I think, can be relatively reliable with any device. I mean, most of my experience, we use mostly the Cirrus Angioplex at all of our centers, and then at our main center, we have a Plex Elite as well.
Yeah, it's been interesting watching the evolution of the software, because we started out with OptiView, by far was what we were using most, and we have the Plex Elite and we have Cirrus as well, but our workhorses that are all throughout our offices are mainly Cirrus. And I will say we have seen an uptake in OCTA ordering in 2025 compared to 2024 at Cole. And I guess one of our challenges has been the impact on workflow. and speed and throughput for patients in deciding when do we really need it and when do we not. But I will say, as we've gotten more, I personally have learned a lot more of where you see more than what you did. I felt like we had a huge amount where we got really frustrated because it wasn't as good as what it should have been. So any questions from the audience at all? Danny?
Vas, you kind of almost led into my question. In uveitis, sometimes we have these CNVMs that we're not sure if they're more steroid responsive, inflammatory versus anti-VEGF responsive. Obviously, OCTA sometimes can help with that, but do you think this nice high-resolution OCT you have can provide any clues to that?
So a lot of times those inflammatory neovascular membranes tend to be type 2 or subretinal, and so you just see some subretinal hyperreflective material. I think it's much more difficult to delineate. Even with high res, I think it's difficult to see the vascular structure within those types of lesions because there's a lot of associated exudation and other things which can be very sticky to the vessels themselves, so it's hard to resolve. So I think you still need, that's actually one of the perfect indications for OCT angiography. Another situation is in central serous patients where it can be difficult to, even with fluorescein, to distinguish whether there's neovascularization or not. So in those situations, we actually sit and take the time to try to adjust the segmentation or keep manipulating the boundaries until I'm confident that there isn't neovascularization there.
Great, thank you.
I would argue, Vas, that you don't even need to have it show up. As long as I see on FAS, as long as I see the flow between the RPE and Brooks membrane, I'm convinced, or above the RPE and not a result of shadowing or projection artifact, I'm convinced I don't need to see the whole complex.
Yeah, no. Yeah, I wasn't suggesting that. I was saying that, yeah, I agree with you. So I think on the B, if you look at the B scans alone, if you can exclude, sometimes it's very difficult to exclude projection artifact, where you see that there's vessel signatures above, and you're wondering, okay, all of them correspond to vessels that are in this deeper complex, and in those situations, then the on-FOS view and seeing the pattern of the vessels can be helpful. But some of the examples Amani showed is very clear that there was nothing above that could be causing that projection.
One other area, which as you see more and more, it's relatively straightforward, but as you're using OCTA early on, is GA and atrophy can easily be mistaken for CNV network as well if you're not used to seeing that. So, all right, perfect. Hadi.
As you're reminding us in your presentation, hypertransmission is a part of the definition of C-RORA. And so looking at some of your, either the high-res or the adaptive optics OCTs, that hypertransmission was not really there as much or as visible as it was in standard OCTs that we're used to looking at. Maybe it's more of a comment or an observation than a question, but I mean, how do you anticipate that definition being changed or reformed as we move forward with high-res imaging modalities?
Yeah, actually, that's actually not so that's actually not what I showed. Actually, the examples I showed, it's interesting, we didn't expect there to be a benefit in the hypertransmission defect with the high-res, because one thing I didn't mention, because I didn't have time, is the high-res OCT, the center wavelength is shifted to being slightly shorter, so it should be less deep penetrating compared to standard res. And so we thought actually it would compromise or maybe have some impact on visualizing some of these things, but actually no. The one example I showed with the quantitative that came from that paper where we looked at the quantitative measurements of, for example, hypertransmission defects, the EZ defect and the like. In that paper, there was a clear benefit with high res, and it actually was more easily visible on the high res. And I don't actually have a good explanation for you for why that should be actually, but it is.
Great. So we're going to keep moving on. So our next speaker is Dr. Catherine Talcott from Cleveland Clinic, and she's going to be talking about imaging in the operating room and updates on heads-up display and intraoperative OCT.
Awesome. So just changing little gears as we move down to the surgical section. Here are my disclosures. So as we've talked about in retina clinic, advanced imaging is really essential. It's critical for us to accurately diagnose and manage patients, whether it's diagnosing if someone has neovascular AMD, if they have a persistent macular hole after retina surgery, or if they have PDR. Similarly, we can use tools like OCTA to be able to tell if there's a CNVM, if there's edema in the setting of diabetes or a vein occlusion. So we really, in retina clinic, rely so heavily on these images to see patients. I mean, I personally can't imagine functioning in a retina clinic without OCT, and although it doesn't happen very much, I kind of feel like we should just pack our bags and call it a day if our OCT and server is down. However, using these tools intraoperatively is really not the standard for retina surgery. And why is that, and should that change? So sort of for my talk this evening, I'm going to talk about some innovations in surgical imaging, first talking about intraoperative OCT, then heads-up display, and then how can we utilize the two together. So intraoperative OCT is really a valuable surgical adjuvant to ophthalmic surgery that increases our understanding of the pathology of surgical disease and can provide really like real-time feedback to us as retina surgeons. Here's an example of doing a membrane peel for an epiretinal membrane, where you can see as you're pulling up on the membrane that's present, you can see that the traction that's actually there. Similarly, if you're doing cases like I did one of these last Friday where you inject TPA for like macular hemorrhage, you want to make sure that the cannula is under the retina but not under the sub-RPE space prior to injecting, or even for more complex cases for being able to tell depth if you're doing something like scleral windows for uveal effusion syndrome. So, intraoperative OCT can really provide us with additional information on subtle changes in the retina in response to the things that we're doing, and can help us to guide maneuvers that are necessary, but trying to also avoid unnecessary ones. And it may lead to safer and more efficient surgery, but really in order to be able to prove this, you really need to have sort of outcomes and data to be able to show that. So really a lot of these studies were done at Cole under the leadership of Justice, including the Pioneer study and the Discover study, which showed that intraoperative OCT actually enabled altered decision-making in 29% of these cases. So I'm just going to offer some of sort of the examples of different types of cases that it can be helpful for. Macular surgery I personally find to be the most helpful, and it can really help to reveal if there's any membranes that are sort of left behind after you think you've done your peel, and then as well as to see if you think that there might be a defect there that you can't quite tell. Maybe you're more likely to use gas in those cases. But in the studies, it was shown to actually be pretty beneficial in showing that there's 43% of cases that our decision-making at surgeons is changed. And retinal detachment surgery can also be really helpful. I found it really helpful if I'm putting in PFO for these cases. I can see if there's any persistent subretinal fluid that's present, as well as to be able to evaluate for PVR membranes, especially in the setting of sort of immature membranes as well. PDR can be very helpful too, especially if you're doing a case where there's like non-clearing vitreous hemorrhage and you might not have had a lot of OCT imaging before clearing out that blood. To be able to really get you more information, our fellows often ask us, like, when am I done with a case? Like when is the sort of enemy of good is better? And so this can be helpful to get that information that we would normally use in clinic. So there's certainly, though, although intraoperative OCT can be interesting and make for good presentations, there's certainly drawbacks as well. There's certainly no reimbursement that's additional to it. And this is very different than sort of our anterior segment colleagues, where we often charge extra for supplemental imaging and boutique-like procedures that you can do, and it takes time to acquire some of these images that are present. So let's change gears and just talk about 3D visualization systems. So, really operating using a standard operating microscope has really been sort of the standard, but 3D heads-up display can offer a digital stereoscopic view of the surgical field, which really can free the surgeon from being able to sit at the microscope and may offer benefits in ergonomics and efficiency. So there's multiple systems that are being developed, including the Artivo system, the Ingenuity system, the C-Lumis system, and Bionics as well. And really the goal of all these systems is to really create an integrative theater where you as a surgeon is sort of immersed in surgery and being able to see the images and really get real-time feedback on things that you're doing. So this is a system where you can see that as you're sort of looking ahead at the surgical field, you're performing the surgery, but you're also getting input from your constellation system of what the pressure is and sort of what your vacuum settings are. This can be really helpful, especially if you're teaching, to be able to keep your eyes just in one place and get lots of information at the same time. The Artivo system by Zeiss is supposedly the first 3D capable digital ophthalmic microscope and can offer some improvements, especially in surgical field color, as well as an improvement in latency as well, which is sometimes an issue with these systems. And you can see here, when I use this system, I think the coloration is much more true to form, what we're used to seeing. And this can be really helpful when you're sort of doing macular work to sort of peel membranes that are present. This is another system that really offers digital binoculars in a design that really allows the surgeon to look straight ahead rather than having to look around a tower, which can be really nice for ergonomics as well. And the Bionic system is an FDA-cleared surgical platform that uses an augmented reality head-mounted display. So it's a really fully digital microscope, and you can use the exoscope to actually do intuitive head gesture controls to be able to do automatic focus, pan, and zoom, and can offer benefits in really having an immersive experience. And here is sort of an example of this, where you can use head movements to be able to change up and down the focus, and when you integrate it with intraoperative OCT, you can actually bring the retina sort of into focus all with one movement, and you can toggle through these different menus to be able to adjust those things, making you sort of more independent and really get those OCT images sort of next to the retina as you're viewing, and really get high density scans such as here to be able to see what's going on. There's been studies looking at this. This is a study that I worked on when I was a fellow at Wills, which was a prospective study looking at the Ingenuity system. And we found that 3D heads-up display really required lower light levels, but ease of use and peel time was actually better with the standard operating microscope. This is a study out of Mass Eye showing that this is an improved system in terms of immersion of the trainees. But you can see in the red for some of the individual steps that a 3D heads-up system for things like ender laser and closing and scleral fixation of IOL might be more challenging with a 3D system. So these systems have the potential really to change the way that we operate. But I always wonder this question, which is in its current form, can this technology really replace our standard microscope? Can it offer something that we sort of don't already have, especially for our challenging cases? And here are some of the shortcomings that I think of with these systems. You need to wear sunglasses. I 100% forget to put on my sunglasses before I scrub all the time. And then somebody in the room puts it on, and it's never quite right with my hair, and it bothers me. Or you can have these corded devices that are not made for female heads and can be really heavy. You also need to make sure that the machine is in just the right position. There's a lag time with anterior work that can make doing cases like scleral tunnels and suturing a little difficult, especially as you're trying to compensate for that. Some of the images can feel overly digitized, as is in this patient who has asteroid that's there, and the colors can be oversaturated as well, and changing sort of the feedback that we normally get when we're doing things like peeling. Also can be challenging sometimes in these cases are the peripheral views, especially if you run into challenges like this. For a lot of these systems, it's really hard to toggle between using a 3D heads-up system and switching over to your standard scope. So there's things. Sometimes it also being able to see the laser beam is difficult as well. So these systems, I think, it's important to continue to utilize them to really move them forward. But I think the reality of this is you always have to keep in mind is that any system, especially like an ASC, is only going to be able to purchase so many scopes. Can this one scope do all the things for all the people in your ASC? So then I just wanted to finish with just how do we integrate these two technologies together. We've looked at through Justice's lab of how we utilize intraoperative OCT, finding that, initially that most people would visualize this on a 2D system, allowing you, which would force you to look away from the scope. And so we looked at, is it better in these 3D heads-up systems to be able to look at these images on the surgical field or sort of away from it? This is a study that was published looking at the Ingenuity system, which showed that if you're using 3D heads-up display, that you're much more likely to be able to look at the surgical field where the OCT images are present than looking around. And we looked at the Artivo system as well and found this to be the case. And this is probably just related to the quality of the intraoperative OCT images that are in your oculars versus on a 3D heads-up system. So really what's next for this? I find these technology to be really helpful for some of our sort of more challenging cases when you're trying to decide how much space is there between membranes and sort of the retina for you to be able to sort of get space. And if you're like in this complex TRD where admittedly I used way too much steroid, making it harder to see the fibrovascular membranes, I was able to see that there's space there and then to feel comfortable sort of going in my, with my cutter here. You can tell sort of how much traction you're applying to the retina and making sure that there aren't causing any sort of defects. The Bionic system can help with this as well. It can be helpful for things like cornea surgery, seeing good anterior resolution, as well as for 3D, for retina surgery to be able to tell, the video's not loading here, but if there's any defects that are present, here it goes. you can get real-time interoperative OCT to be able to see if there's any defects, really scanning around to be able to see potential planes. That would be helpful to start. This can be really helpful when you're operating with fellows, as well as to see where the retina is. So in conclusion, really, there's a lot of potential for innovations in this area that can be really helpful for us in terms of teaching, understanding the retina, as well as ergonomics. And these systems may be the future, but they do need to offer something that we currently don't have. And so there's really a need, I think, in this field to really look at more outcomes-based research to be able to show what can be useful and what can't. Thank you.
Next speaker is Dr. Danny Memo from Cleveland Clinic, and he's going to be talking about how he uses imaging to plan for vitreoretinal surgery.
Thank you, Sumit. Thank you, everyone. These are Kat's acknowledgements. All right, so how I use imaging to plan for vitreoretinal surgery. So, we all know basic things. We all know you got to get a B scan and a non-clearing vit hemorrhage to make sure the retina is attached, changes your surgery. We all know you'll use OCT to measure the size of a macular hole. Larger mac holes, you might change your surgical approach. But I'm going to talk about some maybe less common, more practical tips to kind of just make your OR day a little bit more smooth. We're under more and more pressure to do more cases, to finish on time, to share OR days with people. Every minute honestly matters. My disclosures are not relevant. So we'll start with a case. This is a 61-year-old female, same day add-on for a vit buckle, had only seen our fellows. One of my colleagues was on call. And I was finishing early. So they said, oh, can we add the case? So I was booked for a vit buckle. There was a prior exam from our wonderful fellows, but fellows, make some mistakes. So 1 plus NS, exam doesn't have any photos. I'm in Friday OR, so I'm asked if I can add this case. I say sure, but we're gonna get some photos first. So this is 2400 MAC off. Looks chronic. There's actually a cyst infratemporally. Looks like a dialysis versus a GRT, but I can't really depress this patient until they come to pre-op. We have to get OCT, and I like to get a raster over the nerve and the macula. So here we see an OCT over the nerve and the macula. It's a little bit more grayed out than it was on my slides, but here's another photo, and you can see that the hyaloid is very much down. So this is not a case that I'm going to do a vit buckle on. So very important to know. So the surgical order was changed, surgery plan was changed. And yeah, I looked at this patient in pre-op, but let's be honest, in pre-op, was I really going to know if the hyaloid was attached by looking at her with a 28 diopter and indirect lens? Probably not. And let's say you don't get an OCT over the nerve. This is just your regular macula scan. You can see there that you can still tell that the hyaloid is down. So it's really important to train your eyes to look at not just the retina when you get an OCT. So this patient got a buccal cryo drain and did pretty well and was saved from getting a vitrectomy. Here's an 80-year-old female saw recently for a second opinion. She has recurrent vitreous hemorrhages in her left eye. She's 20/30 in the left eye, and she's pseudophakic. So she's pseudophakic, she's 80 years old. I mean, this lady has a PVD, right? She has no TIDs. UBM confirms UGG. It's because the IOL is chafing on the ciliary processes, not the irises. That's why there's no TIDs. So here's her Optos photo of the left eye showing vitreous hemorrhage, and here her OCTs. We can see that in both eyes, right and left eyes, her hyaloid is down. So we go to surgery, and fellow clears the hemorrhage. Fellow checks for PVD, very happy with what they see. Sometimes I kind of just let the fellow do some stuff while I just test them. And they resume vitrectomy. They go to the periphery, and this is basically how it goes. I ask if there's a PVD, and they know they should check for a PVD when they come in my OR, but they don't always. So they say, this fellow starts sweating, shoot, I forgot to look, but she's 80, let me just lie and guess and say, yes, there's a PVD. And so I say, nope, let's still check, let's get Kenalog, and then the fellow realizes, oh, I guess there wasn't a PVD. We get an OCT on everybody, anyone that walks in the door. So I recommend you use it to help you think faster and smarter intraoperatively. My scrub tech basically knows if I'm opening Kenalog for any case. They have it open if I need it, and I know if I need it. I don't open it just for any case. So vitreous status can influence the type of surgical procedure chosen. When I was a fellow, once I was operating Dr. Kaiser, and I asked him why we were doing a vit buckle on this patient that I thought we were going to do a vitrectomy. And he said that, I just use my spider sense. And we all kind of develop a spider sense. And I think using multimodal imaging and looking at the vitreous status can help influence your pre-surgical spider sense. OCT is more practical than B-scan. You're not going to get a B-scan on most of your patients. B-scan is highly operator dependent, and not all images get saved for retroactive review and dynamic review. OCT review, though, is also reviewer dependent. So it's important to kind of start looking at this and sharpen your skills. But if you look at the literature, actually, OCT is not supposed to be that great. B-scan is apparently more sensitive, based on literature, for detecting a PVD. OCT in the literature has a sensitivity of 50 to 70%, specificity of 80 to 90%, and B-scan's a little bit higher, at 60 to 80%. But what are these studies? So there's a few case series out there, large series that look at the sensitivity and specificity of B-scan versus OCT. These are 6 cases from this study, and if you look at the top 2 pictures, those are both pictures that they said had PVDs in the study. And they graded them as being incorrect, because when they went in, they saw that there was no PVD. But if you look, those patients don't have a posterior vitreous detachment. Here's another study. They did not show any images, but the way in their methods they defined a PVD was a posterior vitreous detachment was confirmed on SD-OCT when a hyperreflective linear signal was clearly separated from the neuroretina. But we just saw 2 pictures where the hyperreflective signal is separate from the neuroretina, but it's attached to the nerve. So for our purposes, intraoperatively for retina, it's not a vitreous detachment. So do I trust the OCT interpretations? I'm not really a very trusting person. So if it's in the literature, I don't really trust them that much. Who are the graders? Are they looking through every raster? And how do they define PVD? These things are important. So when I was a resident in Minnesota, this is my best friend, co-resident Sushant Wagley in Iowa now, and then Ed Ryan, excellent retina specialist in Minneapolis. They get these scans on everybody, and they looked. They utilized SD-OCT to identify PVD in patients with RD, and they were very stringent. They basically do what I do. So I learned it from them. So all 31 rasters were reviewed, and to define a PVD, they had to have separation of the posterior hyaloid on all 31 rasters. If it was attached to anything, it's not a PVD, because we know that it's going to be attached intraoperatively, and you got to lift it. A partial PVD with the hyaloid detached in the premacular space, but not at the optic nerve, was coded as not having a PVD. So very important to look at your pre-op OCT. But I can be wrong. So luckily Sunil's not here yet, but this is where I kind of failed my new boss. So this is a back-off detachment that I saw in my clinic, a Monday clinic, seeing a ton of patients, retina, uveitis, and I get to have my colleague at it the next day. I'm quickly looking through the scans. She's, above 60. She has a rhegmatogenous retinal detachment. I see hyperreflective dots that have been well described on OCT and PVDs with a retinal tear, and some hemorrhage. But I don't really think I see a PVD on my exam. Sorry, I think I don't see the posterior hyaloid face on these images that I think. On my exam, I did think I saw a PVD, but let's be honest, we're all retina specialists busy through our clinic, and whenever we're not doing the surgery, we're adding it to our colleague, we pay attention slightly less. So I add on to my colleague, and I'm doing a vit buckle. And sure enough, op note with one of our wonderful fellows and my partner, they had a very adherent hyaloid. So, in retrospect, if I went back and looked at all the rasters, I do see that this patient, this is probably the premacular bursa that I was missing, that should have tipped me in. When I prepare for surgery, I say yes, PVD, no PVD, or I say unsure. This is probably one where I should have had some better spider senses and probably said unsure, and that might have influenced my surgical decision-making and what I recommended. So we're going to transition to another pearl, but still stick to the hyaloid for now. This is a 69-year-old male, 4 months of a chronic RD, pseudophakic, and had a trauma. So this guy has a lot of risk factors for a PVD. Trauma, pseudophakia, rhegmatogenous RD, 69 years old, 2,300. So if you look here, you see that this patient's hyaloid is down. So posterior hyaloid is known to be attached. In my surgery, I knew I was going to use Kenalog to lift. But this is the choroid. So choroid's thick. On my pre-op B scan, the choroid's thick. So this is another pearl. Pre-op B scan and or OCT can help identify thick choroids secondary to inflammation and or hypotony. So this is one where I inserted my trocar straight in, no beveled entry, because I don't want to waste my time and deal with a trocar that's getting, stuck in the choroid. You got to cut retina. You got to reinsert the trocar. All of that wastes time. I'm going to suture these anyway. It's a vit buckle, so I'm just going to go straight in, no bevel like normal. You also want to consider a 6mm cannula for your infusion in these cases when you identify there's a thick choroid preoperatively. So in inflamed eyes or chronic RDs, with or without hypotony, consider choroid status to influence your trocar insertion. This patient had a vit buckle oil, just took the oil out last week, great result. The last pearl we're going to talk about is a wonderful OCT biomarker that Stanley Chang wrote about a few years ago called schisis of the RNFL. So schisis of the RNFL is diagnosed by OCT and is defined as hyperreflective linear spaces parallel to the ILM. And when they're interlaced and protrude above the ILM, he calls it the spaghetti sign. We'll see pictures in a second. They characterize schisis of the RNFL as being focal or diffuse, within or without the papillomacular bundle, and whether or not they had the spaghetti sign, or when it protrudes through the ILM. So there's one more paper on this big series from Cole with myself, my co-author Dr. Talcott, where we further describe schisis of the RNFL and ophthalmology retina. And basically how I use this is if you look at the image on the left, the top left image, you see a dense ERM, but you actually also see some more bright white fluffy stuff, and that corresponds to the spaghetti sign. That corresponds to the schisis of the RNFL. And you can see when they peeled it, this is from their paper, it totally resolved when they peeled around it. They don't touch the schisis of the RNFL. They just peel the ILM and the ERM around it. Bottom image, you see the same thing, resolution of the spaghetti sign postoperatively. Now, intraoperatively, these will look as white tissues, and I've seen this before in fellows and when I was in fellowship. You'll waste time after your peel. You'll start touching this stuff and wondering, should I peel this, should I not? It's kind of gummy, what's going on? No, if you know it's there beforehand, you don't have to waste your time. This is another series from them where they show the images of it preoperatively and postoperatively. And then these are some of my cases. So when I identify these beforehand, I know where they are on imaging, I know where they are in the macula, and I make sure that myself or the fellow doesn't peel them. I just peel around them, otherwise you're going to get damage to the RNFL and the ganglion cell layer. Here's another case, didn't touch it, just peeled around it. They resolve nicely on their own, and you get to keep your nerve fiber layer. And here's the last case. So for schisis RNFL, look at the macular croup prior to ERM and mac hole surgery. Avoid peeling. Thank you.
Final speaker for this section will be Dr. Yasha Modi, and he's going to be talking about retinal displacement after retinal detachment surgical repair.
All right, Danny, that was an awesome talk. And just a show of hands in the audience, who's in training? Show of hands. Wow, awesome. And how many are residents? How many are fellows? How many are med students? All right, cool. Got a ton of fellows. So we'll go on and we'll talk a little bit about retinal displacement after retinal detachment. We'll talk a little bit about the imaging. And I'm really glad that we have a room full of residents and fellows here. This topic is somewhat controversial. I'll highlight where we have evidence and also where we don't have any evidence. And similar to Danny, I think Danny and I have the same exact fellows. But this is a text message from my fellow. We're getting close to graduation, so I just get a sticky note. And the question is able to add on tomorrow. And when you look, it's a bolus detachment, multiple breaks lattice. So not that uncommon. And I agree with Danny, the only way to succeed is always check the posterior hyaloid. So I love the fact that he's checking the posterior hyaloid in all retinal detachment cases. So you've got a couple of options: scleral buckle, pars plana vitrectomy, buccal vit, pneumatic. Truth is, probably all of them could work, right? And so this is kind of the thing in surgery, is that oftentimes you kind of have to do what works best in your hands, but can we use the literature and use some imaging to help us succeed? And then I guess you have to ask yourself, what defines success? Is that vision? Is that single operation success? And then what does the patient define as success? Because those may be two totally different things. And so when we look in the literature, single operation success is defined by the sort of anatomical standard. And what you can sort of see is that the visual acuity outcomes are similar across all of these. The success rate is similar. Pneumatics is obviously a little bit lower, but there's no difference really in final best corrected visual acuity. And so this is a patient of mine that kind of regrettably, I would say, that sort of changed the way that I think about retinal detachments. And then I have to kind of credit a few people for this, and I'll just name them: Justice Ehlers, Rajiv Mooney, Cynthia Toth, and Barbara Parolini, who've kind of changed the way that I think about this. But what you see is somebody who had retinal detachment surgery with me, and afterwards their vision's awesome. It's 20/20 minus. But look at that inferior arcade, look at the near infrared, you see these sort of hyper-reflective lines. It almost looks like the retina is sort of dragged down, and you get this significant vertical metamorphopsia and monocular doubling. And I actually removed the buccal, and the patient still didn't have resolution of their symptoms. And you see these sort of outer retinal folds. And so what are some of the imaging findings that you can use when you're thinking about sort of what defines success? So this is the old definition: single operation success, visual acuity. It's the gold standard. We can never deviate from that gold standard. This has to be paramount. But the reality is, as we move into the modern era, we really should be thinking about what defines high integrity retinal reattachment and how do we minimize the symptoms of distortion to the patient, which really is what the patients care about the most. So what are these metrics to evaluate what we would define as high integrity retinal reattachment? Is there a surgical technique that maximizes this and reduces metamorphopsia? And if so, what lessons can we learn to modify our surgical approach, specifically in vitrectomy? So I think we're all pretty familiar with the idea of high and low integrity retinal reattachment because it's gotten a lot of noise over the last few years, rightfully so. And what you see are these sort of hyper autofluorescent lines that are typically above the darker vessels, and they correspond directly to them. You can see those arrows there, and this sort of ghost vessel or retinal vessel imprinting is thought to represent the original place of where those vessels were before retinal detachment surgery. And either way, whatever the theory is as to what this is, we know that this correlates very heavily with metamorphopsia. And so there are also other features that you can look at when you're sort of counseling your patients after surgery. Easy ELM loss correlates with decreased vision and increased metamorphopsia. But the good news is that if you do see an intact ELM, this may be something where you can counsel the patients about resolution of their symptoms, which is going to be more probable. So two good OCT features to look at. Now this one, outer retinal folds, there was a really good presentation by Rajiv not too long ago that showed that these outer retinal folds occur as there's more chronicity to the retinal detachment. But the problem is when they get reattached, these outer retinal folds are associated with metamorphopsia, and the density of these can predict metamorphopsia scores even out to 6 months. And so finally, subretinal fluid in the macula greater than 6 months can result in poor functional recovery, but arguably this is something where we don't have a meaningful way to get rid of these pockets of subretinal fluid with surgery. So when you're thinking about your patients, we can be a little bit further than just the binary attached or detached, and we can look at some OCT features to help us understand their symptoms a little bit better. But are there differences between surgical techniques? So I think we're all pretty familiar with the fact that displacement rates are probably lowest in a non-drainage scleral buccal, followed by pneumatic, followed by vitrectomy, and there's good data supporting this. So where the rates of vitrectomy, which is the thing that I'm interested in the most, is that there's massive variability in the rates of displacements, mostly downward, suggesting a gravitational component to this. So we learned from the PIVOT study that, and really props to the Canadians because I don't think my success rate with pneumatic is 80%, but that's really, really impressive. And they even showed that with pneumatic that there was a 5-letter gain in vision relative to that of vitrectomy, but this was heavily biased by the fact that many of those patients were still phakic after vitrectomy. Most notably, though, this is really what changed the paradigm, was that retinal displacement was drastically lower for pneumatics relative to that of vitrectomy. And this was not horizontally focused, but rather it was about vertical metamorphopsia, suggesting some gravitational pull acting on the retina. So pneumatics, lower single operation success, but less vertical metamorphopsia. So how do you explain this then? How do you sort of look at scleral buccal without drain and say this has the lowest rates of distortion? Well, perhaps this is because of passive absorption of fluid may be better, maybe a more physiologic way of attaching photoreceptors. And then what about pneumatics? Why is it that they have lower rates than vitrectomy? Well, when you do a pneumatic, you have an eye full of vitreous. There may be more gentle approximation of the outer retina to the RP. And then there's naturally differential buoyant forces of a small versus a large gas bubble. So all things to kind of think about. But the reality is, if you look at some of Danny's sort of retinal images, you can't do a pneumatic on those patients. So what if we have to do a pneumatic? And this is something that I think is something that I'd like to focus a little bit on here. When I was in fellowship, I remember very clearly we were always taught to drain very well. Use PFO, posterior drainage retinotomy, not a cold, by the way. The goal was really to leave the retina dry. But what we've learned since is that actually when you do the drainage retinotomy, the retina shifts entirely to the area of the drainage. And so if you don't give some level of that to subretinal fluid to allow that to kind of move back into its place, maybe we're shifting the retina in that direction. And there was a really interesting paper that kind of helped me believe this, which is that this one paper looked at retinal displacement rates, but what they did was they left submacular fluid and they positioned the patient supine for about 3 hours, and their rates of subretinal of displacement was considerably lower. So then, is perfluorine bad? And we've heard this kind of in the meetings, and the thought is that maybe there's some smashing of photoreceptors against the RP in a non-physiologic way. But actually what I learned from Justice is that when you actually do intraoperative OCT under PFO, what you can see is that there is still, in fact, some PFO and some subretinal fluid, even though you have this heavy liquid over the retina. So I still think perhaps leaving some submacular fluid may be beneficial because you're still draining from that anterior break and potentially resulting in shifting of the retina. Now, positioning, I don't think any retina specialist will necessarily agree on this, but what we can all agree on, thanks to some work published in the Japanese literature, is that brief head-elevated positioning can result in much higher rates of retinal displacement rather than trying to, because of that gravitational pull, rather than just doing immediate face down or log roll positioning. So supine positioning, this was the paper that I discussed, low rates of displacement. So let's go back to our patient. Multiple retinal breaks, multiple clock hours, recently MAC off. Not a great candidate for a pneumatic as a definitive procedure, given the fact that there was lattice and multiple breaks. So how do you maximize the durable retinal reattachment and minimize retinal displacement? And this is something I've been doing a little bit more of late, which is, in this case, I did a temporizing pneumatic. So this is the patient on day one. And you'll notice, again, outer retinal folds, when you look at the OCT on day one, you still see those outer retinal folds. But then I followed it up with something a bit more durable, which is a buccal and a vitrectomy for this patient. So in conclusion, imaging can differentiate high versus low integrity retinal reattachments. Retinal displacement occurs with all surgical approaches. Pneumatics and scleral buccal may demonstrate less displacement, and vitrectomy is essential for high single operation success, and perhaps maybe we need to modify our approach to minimize displacement. Thank you.
Questions from the audience at all?
So I have a question for Kat. These are beautiful videos. I just wonder, how often do you turn on the OCT? Do you just turn it on for education, all the cases, to just teach yourself and the fellow, or do you have a strategy for how to use it?
Yeah, I think that's a really good question. I find it most helpful, to be honest, for macular work, because I think it can elucidate if there's membranes that are still left to peel. The other thing that I get concerned about with cases such as like VMT cases or not is if I've pulled like a hole in the macula, especially for like diabetic cases where everything's sort of thin to begin with. But I have to say, being involved in some of the studies and just for other things that I've done days where I'm just like, we're just going to do intraoperative OCT on all the cases, whether or not I think it's useful or not. And you actually learn a lot of stuff. You're like, oh, there's fluid there. I don't like that fluid there. That's not supposed to be there. Or like, was there actually a macular hole in the first place? So it's actually interesting, I think, if you start to do it on a lot of patients, you actually learn, I think, a lot more.
So the one time I turned it on and I never turned it on again, I turned it on when I was doing the air fluid exchange for a macular hole.
Yeah.
And I thought I was too super dry. I turn it on, I see the fluid coming back. So I dry it again, and I turn the OCT on, and the fluid keeps coming back. So then from that day on, I stopped.
I don't want to know. I don't want to know.
Sometimes not knowing is good. It's the same sometimes when I put the oil inside the eye. I was like, I don't really want to look at it again. I was like, I've been here enough. We're done. We're done.
So, Danny, I'm curious. The hyaloid status on OCT, I use it all the time from the surgical side. Have you ever seen, and we get these interpretations in our clinics where you have the hyaloid elevated, 500 microns above the retinal surface, and the interpretation that I get in EPIC is PVD. I don't think I have ever seen a PVD surgically when I could see the hyaloid anywhere in the OCT view. Have you?
Repeat the question?
So if the hyaloid's up from the macular surface, I've never been in an eye surgically where there is actually a PVD there. It's always attached somewhere, whether it's at the arcades, whether it's still at the nerve. And
If
so,
on the OCT you don't see the hyaloid.
no, meaning
it.
you see
You
like
see
the
it.
posterior hyaloid.
Oh, got it. Yes,
And it's
then there's,
elevated from the retina.
But you see
and
it.
an often
like
interpretation.
in the examples that I,
Yes.
yes.
Yeah, where you actually see it, like the ones where you said they were interpreted as
Yes.
PVDs. And so oftentimes whoever saw it first might say there is a PVD.
Yes,
My interpretation of that is there is never a PVD.
exactly, 100% agree. So
You can see it at all.
that's
It's
where,
not.
that's where I'll have the fellow lift, and if they're struggling, quickly go to Kenalog, or Triessence, and they usually don't have a PVD when you can see it on the face there.
Yeah, and that's because they, when you're looking at z-axis resolution, now, Vas, you can sort of correct me on this, but you're too close to, it has to be attached somewhere if you're seeing it on a standard, spectral domain OCT. There was a paper, well, it was a presentation by Dave Brown a few years ago at ASRS, and I don't know if he ever published it, but he actually said he did a study looking at this exact same question that Danny was getting at, and he said if you just get a spectral domain OCT over the nerve and macula instead of just the macula, it drastically increases your ability to identify whether or not there's a true PVD. So I would argue perhaps if you're doing this for all your patients, probably doing it just those two images as opposed to just one can help you increase that chance.
Yeah, for me, if you can see the hyaloid anywhere on the macula, there is no PVD.
Found somewhere.
So Yasha, one question for you. So what's your positioning for RDs now after vitrectomy? Because what I do is what Cindy Toth taught me, which is any MAC off RD goes temporal side down for an hour. Try to minimize this.
She basically started this process for me when she was really sort of talking about like supine positioning. Barbara Parolini, who I also credited as a like total supine positioner as opposed to a temporal side down. The retina is going to shift in the direction of gravity. So I've shifted away from going temporal side down to more supine positioning. But then I'm a big believer that at some point along the way, our ASC won't let them stay down there for 3 hours. So then I have to log roll them to kind of make sure that they go face down. And I'm an absolute stickler on never lifting their head. And I tell them this preoperatively so that there's absolutely zero inferior or gravitational forces acting on the retina.
So that's why I go temporal side, because I can get them log rolled that way to the face down.
Yeah, that's it. Yeah.
So flipping back, I was curious about why would somebody document there was a PVD and there wasn't. It's certainly verified on the OCT. And I think sometimes you see floaters. You may see a big vitreous opacity and you think, PVD, good. Okay, next, they're detached. Let me get them to the OR. But not every vitreous opacity is a posterior vitreous detachment. Not every floater is a posterior vitreous detachment. So, I think, as you mentioned, the unsure kind of terminology, I think probable, a lot of my documentation, it's like a little note to myself that I'm not sure, and it'll be rare for me to say there's a complete PVD unless I actually see the Weiss ring completely there. And even then, you can be surprised.
Yeah, I trust the OCT so much more than my exam. Like, to be honest, I don't really trust what I'm seeing. I think the OCT is.
So let's with that, let's go to our break. We'll take a 15-minute break. Let's come back at 8:20.
So glad we're having an imaging conference.
Oh, okay. We're starting now?
We're starting now.
All right, you're up. We still have people there. All right, we're going to get started back up. I heard it's been a great conference. And we're going to talk on a review of AI-based DR screening. Adrian Scott, thank you very much for being here.
Thank you for having me, and thank you for the organizers, Sumit, Justice, and of course Sunil, for the invitation. We're going to give a little bit of a review about AI-based diabetic retinopathy screening. These are my disclosures, none are relevant to this talk. So we know the burden of diabetes continues to increase. As of 2019, approximately 463 million people affected, estimated to be greater than 700 million by 2045. So how are we going to see all these individuals with diabetic eye disease and do the screenings. So in comes AI, and AI is here to stay. Whether we like it or not, it is imperfect, but it is certainly something that has advanced quite a bit. In the US, there are now 3 FDA-approved devices, and I'll say a lot of these efforts were led by Dr. Michael Abramoff. This was really one of his pioneering projects, and he produced the IDX program, which is now, it was owned by his company, Digital Diagnostics, using a Topcon camera. There are 2 other commercially available systems called iNook, and then one called AI Health. So one of the innovations is it uses undilated or non-mydriatic imaging to be able to get these images. And in this manner, fundus photographs are autonomously analyzed for diabetic retinopathy. And one of the major points of AI screening in diabetic retinopathy is to be able to say, is in-person follow-up required? So it gives an initial diagnosis, but one of the kind of points of the system is to say whether or not the patient needs a higher level of follow-up, or at least a face-to-face exam with an ophthalmologist, hopefully a retina specialist. A lot of what I'm going to talk about is by a very nice review by Dr. Lee that was given in Retina Today. So who's using AI screening? And all comers, a lot of people are using AI screening now. The technology was actually approved in 2018, and all comers, ophthalmology and our other medical colleagues, there was a CPT code implemented that was approved in 2021. And there are approximately 15,097 claims. And over the years 2021 to 2023, these went up significantly. These authors, Dr. Wu and colleagues, found that metropolitan zip codes with academic centers had more of an increase in the claims for AI-based CPT codes. Any guesses from the audience about what? I've got 3 cities that are reported in this article to have the highest rates of the AI claims. Anybody want to shout out? Anybody know these cities? Philadelphia, yes. Anything else?
Are those the cities?
Those are the cities, yes. It's just like yeah.
New Orleans.
New Orleans, yeah, that's the vibrant one. The middle one was a little.
Pittsburgh.
It looks like Pittsburgh, but this is Dayton, Ohio? I don't know.
Dayton, Ohio.
Yeah. So I was, yeah.
Dayton has a river.
So it's like, that's kind of unusual, but that's who's using AI. So what do these look like? What does this look like in practicality? So a patient has either a handheld or a fixed camera that takes a fundus image. And whether when they're in our doctor's office, not particularly a face-to-face encounter is with their doctor, so they can be encountered or be imaged by a photographer. The photographer obtains the image, and the image gives feedback. Is there artifact? Is this an acceptable image or not? And if it's not sufficient, then the image will be retaken. If it is sufficient, the image is programmed to say whether or not there is referable versus non-referable diabetic retinopathy present. The responsibility is on the particular clinician to discuss the results with the patient, especially if there is a referral needed, and the onus is on that particular practice who obtained the picture. Somehow they have to notify the patient that there has been some sort of abnormality that has been found in the AI. Reimbursement is also something that is in place, although it is fairly modest. It has a CPT code now, and potentially doctors can use this for some of the reimbursements from the screening measures or these MIPS measures that we get theoretically reimbursed for. So this could be potentially helpful for revenue. So the IDX-DR is considered the gold standard, and you can see the sensitivity of about 87%, specificity of about 90%, imageability 96%, and you can see the positive predictive value of 73% and a negative predictive value of about 96%. So any other AI system for diabetic retinopathy screening actually has to meet these criteria at least, or improve upon those. So the IDX is used by the FDA as the gold standard. And another criteria is that whatever AI system that there is presented that exists has to be demonstrated in a prospective, diverse cohort. Some criticism of other AI systems is that they were trained in homogeneous populations. When you can imagine, there might be some very little nuance in the overall population. So this might not be applicable to all different populations. So it needs to be in a diverse cohort. So the IDX-DR, the indication is screening for diabetic retinopathy, adults 22 years old and older with diabetes without a known history of diabetic retinopathy. And if the screening is negative, then they will get this annually unless there's detected retinopathy, in which case the doctor or the clinician who does the screening and has that test under their supervision is responsible for letting the patient know. So what does it cost the patient? About $100. Practices, you can see the cameras that could be available, the TopCon camera, and you can see that costs about $15,000 to $22,000. And then, the IDX software also has a fee. So you can understand that people who do primary care or people who do diabetes care may not be super excited about this, because you can see the onus of a pretty expensive camera and you can see what the reimbursement is, and there's a significant mismatch there. So this was information taken from the American Academy of Family Practice Doctors, and there's some mixed feeling about, is this really a financially lucrative endeavor to be able to undergo. So physicians are mostly enthusiastic about AI in healthcare. So about 68% see the advantage, gradually rising, and about 66% have some form of AI tool in practice in 2024. However, there is concern regarding implementation, guidance, and then, the use for research and the potential for people to do unethical things with AI. There's a concern for potential bias, as we alluded to earlier, accessibility, liability, and declining reimbursement. And if you're a primary care physician, and a lot of what we've talked about at this ASRS is that the outlook for reimbursement is certainly not looking favorable these days. So there are different models. So let's talk about the fee-for-service model. As I mentioned, there's a CPT code, 92229. It's remote imaging, automated analysis, and reimburses about $40. However, if you're going to do the imaging yourself, the CPT code 92227, remote imaging with staff review, the reimbursement is $29. So it's actually more lucrative they'll actually pay more to have a machine do the interpretation than they will have the actual clinician to do it. So the commercial insurance rates are difficult to predict. These are Medicare rates taken from these references below. And commercial insurance rates they do tend to follow Medicare, but they're difficult to predict. But approximately AI screening can be as high as $127, at least it was in 2021. And this is what we get. So this is an example of an iNOOC report. You can see what the fundus images look like, and it kind of spits out whether or not there's referable diabetic retinopathy or not. So a big concern with AI systems is liability. So again, the clinic is responsible for notifying the patient of follow-up recommendations made by the AI machine. There is the risk of inaccurate diagnosis. There is a big risk or concern for maybe a missed finding on a fundus photo, and it's still unclear exactly whose liability this should be. Should it be on the patient? Should it be on the doctor? Should it be on the person who's actually kind of manufacturing the machine? So the AMA stance is it should be on the machine. So this is a patient of mine, and this is, a wide-field photo, and there's no retinopathy noted. So the computer, the AI system would say, okay, very good, no detectable AI, come back in a year. But I just did a little cut and paste. Does anybody see anything wrong with that picture? There's no diabetic retinopathy there. So there's an unusual lesion in the corner there. So this person unfortunately had a peripheral choroidal melanoma. But unless you tell the machine what to look for and you train the machine, it's very specific. It is not trained to look for these incidental findings. So a lot of the question is still, well, who's liable for detecting this and to telling the patient? And the patient could say, well, you took a picture of the retina. How did you not see this? So it's something that could be up for certain contention. This article is from Dr. Owsley and group. There is a group called AI Ready. And this is a group that's currently enrolling patients. It's a biobank. So it's a cross-sectional study targeting about 4,000 individuals with type 2 diabetes. And the whole goal of this is to promote health resilience. So patients can self-report their race, ethnicity, and give blood urine results. Also, potentially, their AI-generated fundus exam. And we're collecting social determinants of health, blood pressure, hemoglobin A1C, and the goal is to really try to put all those things together and to better understand what the person's health status is and promote health resilience. The recent paper came out of the Stanford group. Shout out to the Stanford group for this great, this work by Dr. Chen as the first author. So they tried to see, they implemented their AI program previously, and they tried to give time to get it implemented, work out the kinks, and then follow up in about 2 years. And these authors actually reported a pretty good, improvement rate. So this was a retrospective analysis. The IDX-DR was implemented in about 2021. Again, the primary care physician was responsible for contacting patients with more than mild diabetic retinopathy, or if they had ungradable images, this with the patient said you need to see the ophthalmologist. So over the 2-year time period, the AI system gradability increased from about 60% to 71% in year 2. And how did the authors do this? So they talked about enhanced training and camera utilization to improve the efficiency screening as well as refining their workflow. Okay. What about at Johns Hopkins? So my colleague, Dr. Alvin Liu, is kind of the chief diabetic AI guy. And we deployed diabetic retinopathy screening in about 2020. And there are over 30 primary care sites who are utilizing this technology. And this is from a preprint, but Dr. Liu was kind to share with me a retrospective review compared non-AI versus AI switch sites. So this study reported that a significant number was of over 17,000 patients were imaged with AI, and potentially the advantage of doing the AI screening, as reported by the authors, is that it improved access for historically disadvantaged populations and may be helpful in closing care gaps and increasing health equity in underserved populations in the study period. So just the final slide, I think AI-based diabetic retinopathy screening is here to stay. There are certainly bound to be improvements in the algorithm and technology with time. It may increase screening access, especially for underserved populations, and bring us a little closer to health equity if it's available truly to all. There's also OCT-based diabetic retinopathy screening we didn't really get into very much, but that is also on the market. It may be cost-effective, and you can see the insurers sometimes will reimburse more for a computer doing the analysis rather than the actual clinicians doing the analysis. So it may be cost-effective if used, in a clever way, and it may improve patient satisfaction. Maybe you can save the patient a visit to the doctor's office if they can get right at their primary care doctors, who they're going to be there anyway, and tell them whether or not they have diabetic retinopathy, and you're accurate with your diagnosis. So we'll stay tuned for that. Thank you.
Thanks, Adrian. I think we're going to do questions at the end of this session. That was great. Next is Yasha Modi, who's going to talk about non-perfusion and diabetic retinopathy, also known as Modi, non-perfusion and diabetic retinopathy.
I like how eponymously I'm named the worst part of diabetic retinopathy.
Yeah, exactly.
All right, I also want to show you why fluorescein angiography still reigns supreme in the management of diabetic retinopathy. These are my financial disclosures, and I think we're all pretty familiar with the DRSS. And to the residents and fellows in the room, there will be a quiz on all of these numbers and the corresponding DR level. So please take note of that. But what's incredible is that you have all these stages attributed to PDR, because that's ultimately the thing that we want to prevent against. And we've known for a long window of time that when you get to moderately severe or severe NPDR, that risk gets up to about 80% at 5 years. But what's more interesting to me is that actually if you look at the same DRSS score, we've known for over 30 years that if you take the fluorescein angiographic findings of severity of arterial narrowing, capillary loss, capillary dilation, and leakage, then that incrementally increases your risk. So you have an enhanced amount of information just based on the FA. Now that's just the 7 standard fields, but we also now are aware that there's an entirety of predominantly peripheral lesions, which we got from Lloyd Aiello and Jennifer Sun at the Joslin Clinic. And this ultimately resulted in Protocol AA, where if you look at the exact same level of diabetic retinopathy scoring, and if you look at patients with no perfusion relative to high perfusion, we can see the cumulative proportion of patients worsening through 4 years is drastically higher for patients with high degrees of non-perfusion. Remember, these are the exact same DRS as scores by fundus photography. So, and what if you look at leakage? So put away those other features and just look at leakage. And there was a really interesting post hoc analysis that looked at patients who were receiving aflibercept, and they looked at the bottom quartile of leakage shown on the left and the highest quartile of leakage shown on the right. And when you look at sort of sham in this arm where patients weren't getting any anti-VEGF injections, the cumulative incidence of progressing to a PDR complication or center involving DME was incrementally worse as leakage went up, meaning leakage has a prognostic value. And what about systemic disease? Well, if you look at patients who have basically chronic kidney disease versus those who have normal kidney functioning, we see that there's an increasing retinal non-perfusion is associated with worsening chronic kidney disease. So especially for those who have access to EPIC and also patient medical records, it's so critical to look and sort of, I always try to document where is their EGFR when I'm seeing patients with high risk, severe NPDR or PDR. So what we know so far, risk of DR complications increases by stage of DR, that's very obvious. Non-perfusion, both posterior and peripheral, as well as increased leakage, provide additional risk for progressing to PDR, and CKD is associated with worsening non-perfusion. But the major question is, can we alter this? Is there something that we can do that's actionable to sometimes reverse or modify non-perfusion? And the big question is, does anti-VEGF alter this non-perfusion? Well, we have a lot of data on looking at the prophylactic intervention of anti-VEGF for patients with moderate to severe NPDR. And this comes from Protocol W, and the top-line results going out to 4 years shows that certainly the probability of vision loss from PDR complications or center involving DME is lower for those receiving anti-VEGF relative to that of sham, but there happens to be no visual acuity benefit. But that doesn't answer the question about anti-VEGF effects on non-perfusion. So let's go back to a study back from 2014 by Peter Campicero, and this was looking at a post hoc analysis of the RISE and RIDE study. So remember, these patients are getting monthly injections of 2 different doses of ranibizumab, and what we can see, the rate of non-perfusion remains relatively low over time relative to the sham group. And when you cross over those patients, there does appear to be a slowing of the rate of non-perfusion. So this led to the question, is this potentially dose dependent in what was called the recovery study? So these are patients who are getting aflibercept and then evaluating retinal non-perfusion by ultra-wide field FA. And there were 2 arms in this study, those who were getting monthly injections versus those who are getting quarterly injections. And I think the findings are pretty fascinating. The primary endpoint is mean change in retinal non-perfusion based on ultra-wide field FA. Now, let's look at the bars in the red. So those are patients at baseline and year 1, and you can see that there's stability in retinal non-perfusion. On the other hand, if you're giving them quarterly injections, it looks like the rates of retinal non-perfusion are increasing. So we can't just sort of say, hey, prophylactic treatment may just look like every quarter anti-VEGF if we're arguably trying to slow retinal non-perfusion. And another question, are there differences between medications? And the answer is we don't know the answer to retinal non-perfusion, but we did talk about generalized leakage as potentially a marker for progression to PDR. And so in the Yosemite and Rhine study comparing faricimab and aflibercept, actually Justice was instrumental in the study, and I believe your lab actually did the analysis to this. They looked at generalized leakage as well as MA counts, and what they identified was not only was there a reduction in the amount of MA counts for faricimab relative to that of aflibercept, but there was a marginal benefit in generalized leakage area for faricimab relative to aflibercept. So some biological plausibility for one drug being potentially better than the other. But how do you then address retinal non-perfusion? You have monthly anti-VEGF treatment, but not quarterly or PRN. So really, really important, if you're going to use anti-VEGF with the goal of trying to lower non-perfusion, these patients have to really be treated at a monthly basis. The other strategy, gene therapy to deliver constitutively active anti-VEGF expression. Well, this may slow non-perfusion progression. We don't have data on this, and then you incur all the risks of gene therapy trials for that goal. And then actually Justice presented some really cool work today that on treatments that alter non-perfusion, something called the endothelial antagonists, and there are other pathways that target semaphorin as well. So in conclusion, non-perfusion and leakage in DR are associated with greater risk of disease progression. Anti-VEGF has a complicated relationship with DR. It improves clinically apparent DR, that's very obvious, but it doesn't have a large or consistent impact on non-perfusion. And the only way to sort of slow non-perfusion is with consistent monthly therapy. And new targets are addressing reperfusion. Thank you.
Thanks. I think we're going to do Voss's talk now because I think, Voss, you have a place to go. And so if you could pull up Dr. Sada's talk on lattice degeneration. And I know Voss and I are confused often, but it is Voss's talk this time. You give my talk.
I really thought I was giving your talk.
I was getting
Okay,
excited.
well.
That would be amazing.
Sorry for the, I hope I didn't disrupt the AV staff too. Okay, all right.
Look at that. That's great. Nice job.
All right,
Thank you,
fantastic.
guys.
Sunil could have given my talk too, by the way. So. Okay, so I'm going to talk about lattice degeneration. These are my disclosures again, which is weird, right, for somebody to talk about lattice degeneration. I mean, it's such a common problem. 7% of people have this. We don't really know why. We haven't really come up with a genetic explanation. Obviously, more frequent in myopes. And we know that even though retinal detachment might be rare with lattice, many patients who have retinal detachment have lattice, right? So that's what the data shows. The interesting thing, though, about lattice, again, as I said, no one talks about it, right? And it's very interesting that actually the best report on this remains Bayer's review from 1979, which is really amazing that we really haven't learned much about this over so many decades. We do know from that original report that when you have it, it's very frequently bilateral, and it's multiple. So on average, patients have 2 lesions, and he's shown that they're located in the far periphery. And there was a number of different features that he identified, right? Norman Bayer identified with pigmentation, this whitish yellow flecks being the most common, but some other features that you can see there as well. And everyone here has seen these lesions. The interesting thing, though, is, and maybe it's not that surprising, since I've said there's been a dearth of data over so many decades, right, that we don't really have level 1 data that guides management. I mean, oftentimes patients come in with questions of, do I need to apply prophylactic laser? And every few years, the Cochrane Consortium sort of does a review and comes up with you know, what do we know? And they basically said, we don't know a whole lot. And they said they highlight a lack of evidence to suggest prophylactic laser. And in fact, the Academy has a position on this that everyone should be aware of, that whether you have holes or not, the Academy's preferred practice guidelines do not recommend laser treatment, although they also acknowledge that if you have a fellow eye that has an RD and you have atrophic holes in your lattice, then they say, well, we don't know what to do. There's no consensus on the treatment. So that's directly from the AAO's position. And so far, like most of our approach has been, you know, people sort of do dynamic indentation ophthalmoscopy, which is kind of becoming a lost art, but very important to assess what's going on. And sometimes we try to look for traction. We say maybe there's some fluid, maybe that should impact our decision making. But we've also seen from several studies there can be quite a bit of variability amongst clinicians. And part of the reason why have we had such little good evidence on what to do is because these are lesions that are difficult to image, right? Because they're generally located anterior to the equator. And we've had trouble being able to evaluate them with modern multimodal imaging. And just to remind you about, just with regards to the standardized nomenclature that we use for describing findings, you know, this was from a paper from several years ago where we had proposed that we used common easy to detect landmarks to define this kind of stratification of where lesions exist in the fundus. Posterior pole is the retina just within the arcades and slightly beyond. The mid-periphery being up to the vortex vein ampulla. And then, it's pretty easy then, right? Far periphery is beyond the anterior edge of the vortex vein ampulla. And so if you're wide field, you kind of got to that mid-periphery. And if you're ultra-wide field, then you'd have to get out to the far periphery. So we wanted to try to have some kind of standardization of the description. But the point is that this is where most lattice lesions lie. And so we have devices, as we've heard already, that give us wider and wide field. So it's just important to understand that wide field OCT does not necessarily mean far peripheral OCT, and that's where most lattice lesions are. And so people have made sort of Herculean efforts to try to study these lesions. So Net and Chowdhury demonstrated that even with a spectralis, if you have a operator who's very skilled and a patient who's widely dilated, you can angle it and try to get far out there. And he actually showed some beautiful imaging of far peripheral lesions, which was pretty spectacular. But again, not easy to do. This was a very nice paper from a group in Taiwan where they actually used this to study lattice lesions, and they saw a lot of interesting observations. I'm going to talk about this in more detail, where you can identify areas of traction and fluid that might not have been apparent on clinical exam. So that actually got us interested because now we have newer technologies, we have devices that we can do steered imaging, like in this example of a patient who you can see has a dialysis, and you can actually get out to the aura in some patients with OCT. So that's made these kinds of things potentially accessible. So whether you use a steering capable device, or even if you have a wide field OCT device, some of them allow us to still angle the patient. A little easier to get out there when you're scanning these big fields. So that's allowed these lesions to now become more accessible and for us to be able to study lattice lesions. So what I'm going to show you is the results of a study that we did in collaboration with a colleague in India using the Silverstone device to actually prospectively image lattice patients, and then we reviewed them all in the reading center in a mass sort of fashion or independent fashion for multiple graders, excuse me. And so some of the common features, some of the things are things that you would expect, right? We all would expect with a lattice lesion, and in terms of recognizing these areas of vitreoretinal adhesion. That's pretty characteristic of these kinds of lesions. Also, again, things that were that Norm Bayer established, right? So we can see that there can be areas of thinning of the retina. Here's again sectioning through one of those lattice lesions out in the far periphery. And then, of course, here's just another example of a pretty profound retinal thinning. In this case, where actually you saw a little hole go by. I'll talk about holes in a second as well. But another thing that we were quite struck by that we weren't expecting, and I'm going to try to make a case that this may be quite important, is that the choroid was abnormal in these patients. So most of the time, the choroid was actually focally thin, but sometimes it was thick. And I would argue in both cases, whether you have pachyvessels or not, the choriocapillaris will be quite deficient. So you might start thinking about how that might play a role in terms of the pathophysiology or pathogenesis of these lesions where you have retinal thinning. Another finding that we were quite surprised to see, but maybe shouldn't have been because this might correspond to some of those whitish lines, is intraretinal hyperreflective foci. Clearly this looks different from that hourglass kind of lesion that I suggested with retinal capillaries from high-res OCT. You can certainly see cystoid spaces in some of these, and of course I already commented on atrophic holes, which are not infrequent in these eyes. And we saw many cases where we did dense sectioning through the lesion. We could not identify any areas of a dehiscence, yet we could see areas of subretinal fluid. Now, what I'm not showing you is, should we be treating these kinds of lesions that have these configurations? I don't know the answer, but I'm hoping that I'll get enough people interested here that we can start to find that out. And of course, we can see lattice even in areas where, actually I have to say, I wasn't sure that this patient had schisis, but obviously they did. So, so Amani is saying I just didn't do a good indentation exam on this patient. And then, of course, there's also, this I wouldn't call a hyperreflective foci, but we saw these interesting things where the retinal tissue was hyperreflective. I have no idea what that is, but that was not an infrequent finding. Well, it wasn't say it was less common than some of the other findings. This is a summary of of a catalog of the different findings that we observed. But the interesting thing that I want to highlight was, again, retinal thinning, vitreoretinal adhesion, they're pretty universally present. Nobody in this panel is surprised by that. But the interesting thing is the choroidal abnormalities. Just about every patient had a choroidal abnormality. It was a very consistent finding in this cohort of patients. And so that's really the big new information. Again, the hyperreflective foci, the increased retinal reflectivity, also interesting findings. Some of them I'm sure correspond to the whitish yellowish flecks and things and pigmentation that Bayer described, but I don't think that's the only thing. So that's something we have to sort out still. Again, I will say that there are some smaller studies. Ours is probably the biggest so far looking at this. This was from a study I think in Korea, where they interestingly found, which I thought was strange, that vitreous traction was present in only half. That doesn't really make a lot of sense to me. But again, they found small dehiscence and things that were not evident on exam. So again, should we be treating those patients? Maybe. I mean, maybe this is going to help us figure out which patients to treat. So we have obviously a lot more work to do. What we really want to know is which of these features actually are associated with a high risk for detachment. The problem is, of course, with these lesions that the rate of detachment for an individual lattice lesion is pretty low. So if we're going to do this, we need everyone here to collect these cases so we can actually study that kind of a question. So in any event, my point is that these lesions we can access now pretty consistently. There's an opportunity to study them. And the critical thing I want to throw out for this group to consider is that not only do you have vitreous and retinal abnormalities, but they're choroidal abnormalities that are commonly observed, and we wonder whether choroidal ischemia may actually play a role in why these lattice lesions actually develop. And as I said, these various features we'll have to see if they actually can predict who's going to have problems. And again, I want to acknowledge my fellows who worked on this project as well as our collaborator at Ames in New Delhi. Thanks very much. I can do questions now, Sunil.
Yeah, we're gonna do questions now perfectly. So good timing, just for you. So I'm just gonna ask you the first one. You have amazing wide field fundus photos on those images. Why do you need the OCT? I mean, in the practical sense. I mean, when you have
you
that.
You think I can infer that choroidal thinning?
I'm just saying, I guess you could infer changes, right?
I know you can, and Fauzi can for sure. She can see
the
thinness of the choroid below.
I mean, I guess the question I would I'd say is the observing these on fundus photo features prospective. I don't know if we've done that enough to see if there are changes that could be predictive.
You're totally right. I mean, it's possible that if we just spent more time cataloging the fundus features, perhaps we could get that. Also, I thought you might say, well, why not just train an AI model using the color features and see if it can predict the OCT findings? That may also be possible.
Well, I was going to ask that, but fine. I mean, I know you got to go, and you just want to cut through my questions. So it's fine.
No, your point, as usual, is very well taken. So,
Vas, go ahead.
No, go ahead.
So we see often different phenotypes of lattice, depigmented, pigmented lattice. Were you able to pick up any specific differential OCT features?
Yeah, there is a correspondence. I mean, again, even though ours is probably the largest cohort so far, it's still small. Yeah. And so we haven't actually done those point-to-point correlations yet, but we can. And some of them do, but we have not found an explanation for that little patch of hyperreflectivity I showed in the retina. I'm not sure what that's about. And all kidding aside, I mean, I couldn't tell. I wouldn't have been able to tell the localized choroidal abnormality until I see that. I really think of these lesions now as vitreoretinal choroidal lesions. They're not just vitreoretinal lesions as I used to think about these.
Yeah.
That's great imaging, especially of the choroid. It makes sense to me to call the choroid thickening abnormal because it seemed like the surrounding areas were thin and then the underlying was thick. Do we have normal peripheral OCTs though? Like, would the choroidal thinning be technically abnormal, or is it?
Well, no, as I said, it's localized, right? So we looked at it was thin relative to the adjacent areas. So obviously the choroidal thin naturally as you get further to the periphery. But I'm saying in the lattice area, sometimes it was paper thin or really quite a bit focally thin. And so that's why we know that if you have pachychoroid, you can have choriocapillaris ischemia in that area. if you're having a thin choroid, obviously choriocapillaris ischemia is. I'm proposing to you all to consider that maybe the choriocapillaris ischemia may be driving why the retina is thin in that location, and that leads to some of the secondary changes.
Have you looked out of curiosity, those are super cool images, at eyes that had previously treated laser, a lattice? In other words, a lot of times when we're operating on like patients who've been previously treated, the breaks occur just at the posterior margin of lattice. So, or of the laser, I'm sorry.
Yeah.
So have you looked and say somebody got treated for lattice like a couple of years ago, have you looked at the OCT features to see what it looks like where the laser has been administered?
No, I presume it looks similar. People have done OCTs obviously through laser, and you see areas of thinning of the retina and the choroid. I presume it looks similar, but I don't know. Actually, we have not studied that. Yeah, so this is obviously quite early. I in part wanted to present it here, especially we have so many fellows and others. We're going to need to have a large consortium because the event rate of bad outcomes is low enough.
Are you buying us all Silverstones for this? I'm just curious.
Sunil, you're the big man here. You can make these kinds of things happen, not little guys like me.
Oh my God, here we go. Adrian, let's ask you a question now.
So I'm curious. So at Hopkins, you have the systems deployed in your primary care. Did you encounter much resistance with that? And I say that because so Sumit's been quarterbacking for us. The plan was to put the systems all throughout our primary care, and we now are completely redesigning our plan, and we're going to put it into our eye clinics and actually use it in a totally different way, from the eye care side instead of from the primary care side.
Yeah, it's interesting. So certainly there were, the bureaucratic barriers. I think, maybe unsurprisingly, the most challenging is the workflow. Like, what's going to happen, or how do you get those patients in? How do you communicate that that patient needs to come in? Where are you going to put those patients? So they put them all in my clinic? I don't know. So the workflow and trying to operationalize that has probably been the most challenging. The primary care sites were actually fairly, open and accommodating to it for their, to have the clinic, having a camera supplied in their clinic, they were fairly open to that. It's just who's going to do it, who's going to call the patient, who's going to make the appointment, who's going to recall them if they don't answer, and whose fault is it if they fall through the cracks.
So one of the interesting things that we're going to try is in working with our sort of billing teams. You mentioned that the ordering provider needs to communicate that. So we've been essentially told that we can use that as an actual office visit and communicate that, have them have the automated interpretation, and have a provider there who then gives them those results and does the appropriate documentation and actually use it as an E&M.
I like that.
All right. Let's move. Oh, go ahead, Amani.
I had a question for Yasha. So I think one of the problems with fluorescein angiography for counting non-perfusion was shown by the paper from Paris, where they showed that if you compare the same day images taken by fluorescein and OCTA, the non-perfusion doesn't change. What changes is the choroidal flush or the choroidal transparency, because ischemic retina after treatment becomes more transparent, so you see the choroid, and it sort of fakes you into thinking there's reperfusion. Right. So how do you feel about that?
I think probably Justice can answer this a little bit better. I think one of the, working with reperfusion companies is that how do you know what you're detecting is real? In other words, if the panacea of diabetes is reperfusing the retina, how do you know that what you're seeing is an artifact of your imaging modality, which can be shown in OCTA, which can be shown in fluorescein angiography, or you're actually truly doing this? And actually, Charlie Wyckoff has shown some really cool images where people have demonstrated reperfusion spontaneously, reperfusion after anti-VEGF, and progressive non-perfusion in the setting of anti-VEGF. I think it's a really complicated result. And Justice, do you want to just summarize a little bit, like the top line conclusions from your talk today?
Well,
Or just like, isn't that?
So let's go to the next talk. Adrian Scott is going to talk on his
It's important, like,
ahead.
I mean, the basic premise is it's a modest change.
yeah, I mean, to Amani's point about, I think it's really hard in fluorescein to know for sure what's real. The other part of it is the contrast loss because of the leakage reduction. Anti-VEGF takes almost all of the leakage away, and even beyond the choroidal change, it's just not as obvious of what's there. And so, but what you said, Yasha, I mean, Charlie's shown very clear areas with new vessel, what looks like new perfusion, and it's really tough, I think, to know exactly. I think you need something in those, the companies and the new therapeutics, I think you need a home run to show for sure it's real.
Yeah.
All right, thanks, everybody. I think, a lot of what I'm going to talk about is the utility of wide field imaging, and you've heard a lot of this, so hopefully it's a nice review. Disclosure is not irrelevant here. I do have Optos a loaner for the Silverstone machine, so Sunil, I'd like to line up for people that are requesting you buy them Silverstone machines. So wide field imaging is really important for management of retinal disease, screening, diagnosis, staging, management including surgical planning, as we heard earlier, and also assessing response to treatment. And as Vas just elegantly showed, this was a working group that really tried to help us with our terminology. What's standard field? What's wide field? What's ultra wide field? And you can see the different ATDRS 7 fields outlined there. And basically, if you get all the way out to the periphery, that's ultra wide field. Okay, posterior pole, mid periphery, far periphery, and then there's something called panretinal, and that means if you can somehow image the entire retina for 360 degrees. So better understanding what we're talking about. Again, I'll introduce you to another patient of mine, 72-year-old man, type 2 diabetes, about 20 years, doesn't really look that bad, like maybe even like a mild to moderate diabetic individual. But then if you can image him with the ultra-wide field photo here, you can definitely see quite a bit more of the peripheral diabetic lesions, intraretinal hemorrhages. Really important to note there's maybe a little tuft of kind of fibrosed neovascularization there that the conventional image wouldn't have picked up. And, interestingly, also the ischemia of the peripheral vessels there. So ultra-wide field imaging can give you a little bit more information about staging of, for example, a person with diabetes and diabetic eye disease. You can see what the fluorescein angiogram looks like. Quite a bit of peripheral non-perfusion, and this individual's got pretty good vision. But you can see the leakage from that tuft of what I thought would appear to be fibrosed NV, and some leakage from some NV that I didn't necessarily pick up on my clinical exam. And so this did also dictate treatment. So we did panretinal fluid coagulation on this patient and tried to use the FA, the wide field FA, to try to target those areas of non-perfusion. You can see probably room for additional fill-in PRP there, but you can see, certainly less leakage after the laser treatment. So this helped us guide treatment as well. So Yasha briefly touched on DRCR protocol AA was one of the DRCR protocols to determine if the extent and location of non-perfusion on ultra-wide field fluorescein was associated with worsening diabetic retinopathy step score or need for treatment. So this was 508 eyes followed for 4 years. Eyes with greater overall non-perfusion did have a higher risk of progression of diabetic retinopathy step score. And those with the predominantly peripheral lesions had a higher risk of associated disease worsening. So this is something that you're really going to find particularly you can on the wide field imaging. Okay, so here's an example of an ultra wide field color imaging showing high non-perfusion. And you can see outside, you can see the little white schematic is what the conventional ETDRS field is going to capture, but you can see the ultra-wide field images show certainly additional PPL or predominantly peripheral lesions. So you can miss a lot doing conventional FA, especially in diabetic individuals. We had a lovely talk by Vas Sara about lattice degeneration. Who knew lattice was the exciting topic of the night? But you can see a retinal break there, and you can see a very nice image there. Not only can you see it on ultra-wide field fundus photograph, but, in all disclosure, this is challenging. So you can't just go to the photographer and be like, hey, take this peripheral break photo, and it requires quite a bit of expertise and some patient cooperation as well. We can just see this person definitely has subretinal fluid and a retinal break there. Okay. So this is another patient of mine. He's a 46-year-old man with hemoglobin SS disease, sickle cell, and he had a vitreous hemorrhage in his right eye. And you can see the peripheral, almost dehemoglobinized vitreous hemorrhage, which seems stable. The other eye also was seeing well, was better eye, no complaints. And in the past, he'd had some retinal tears lasered before. So this was how he looked in 2024. You can see some peripheral, kind of infarcted CFAN. There's some vitreous hemorrhage there and peripheral CFAN neovascularization. But when he came to see me last week, that little area, again, that's not the eye in question. We're following the vitreous hemorrhage in the right. We can see he's had previous laser, but gosh, what is that? My fellow said, oh, he's got another break. And I was like, no, we're actually looking at the other eye. But sure enough, the wide field image helped me. And then I thought, gosh, did I miss this? But sure enough, he had serial fundus images that really helped to see, no, this was new. And there's a horseshoe tear, that area of the neovascularization definitely pulled a break in the peripheral retina. And just a little clinical pearl, again, where the retina is ischemic, you're going to have very fragile retina. So I'm actually quite worried about this individual. He already had one tear, and then he kind of spontaneously, asymptomatically came up with, we found another tear. So this is somebody I need to follow closely. And actually, his other eye was the eye of interest. So you can see the comparison just over time, just following on the wide field imaging really helped to understand what the pathology was looking like over time. And there's a cup of subretinal fluid around the peripheral tear, and we did laser that. So good for documentation. We talked about neovascularization. Again, ultra-wide field imaging can help tell, and this was a 12 millimeter far peripheral OCT-B scan. You can see that elevation there, peripheral neovascularization is nicely imaged. In response to treatment, so you can have retinal whitening, and in its more active stage, it's certainly more kind of creamy, more fluffy looking, and you can tell after, for example, once it's kind of a little bit more quiescent and responding to treatment, it's a little bit more sharply demarcated, and the ultra-wide field OCT also helps us with that. What about screening? So this is for Sunil. So he said, well, what about sickle cell patients? And this was a non-mydriatic photo. This is we planted a fundus camera made by, trade name, Optos, in the sickle cell infusion clinic. And this was non-mydriatic acquisition of photos, and we were able to image the patients that were there for their sickle cell, just overall hematology visit. And the manager of the hematology clinic was kind of aided by one of our research coordinators and a student, and they were able to take these beautiful photos. And this was kind of the poster child. We were able to find referable sickle cell retinopathy and able to see that patient in clinic to confirm the findings. But this is through a non-mydriatic, non-professionally trained photographer obtained image. What about surgical planning? We heard a little bit about that earlier. So this patient presented to me with 20/40 vision, metamorphopsias. He has a nice, juicy epiretinal membrane, really excited, and that's over the macula. But then the peripheral retina shows this. So this is a little bit atypical, right? So you have to keep this in mind as well. So not only does this person have macular pathology with macular edema and macular traction, but they have this ridge of, neovascularization all throughout the temporal periphery. So certainly you have to tailor your surgical approach to be able to address that as well. And so we were able to do laser to surround that area during surgery. And also another, just to reiterate, you have to be careful about lifting the hyaloid in these patients because the retina is very, very thin when you get in those peripheral areas. Diagnosis, also, ultra-wide field autofluorescence is excellent for diagnosis. You can tell in this patient who maybe would have a conventional photograph, you may have missed these pisciform flecks there outside of the overall macula here, showing hyperautofluorescence. But ultra-wide field imaging, it does have limitations. There's artifact or peripheral distortions. Pseudocolor images are often obtained and they can be fraught with lack of resolution. The higher magnification, I heard this morning, Dr. Blody said it really nicely. He said the more magnification you get, you sacrifice your resolution. It's expensive. And then also there's technical expertise that's needed for acquisition and interpretation. And it does not substitute for clinical exam. That's almost how wide field imaging became very popular among people who thought, oh, it's a retinal tear, I don't have to examine the patient, I can just take an ultra-wide field imaging. But you can get burned during that if you really don't know how to examine the patient and be able to corroborate what you think you're seeing on the imaging. This is an example of a ultra-wide field, or wide field swept source OCTA in a patient with hemoglobin SC, courtesy of Ian Hahn. You can see the significant non-perfusion there peripherally. And we heard a little bit about the Opto Silverstone platform, and that is a platform that's relatively new, and it's able to image both the macula and the peripheral retina. So you can kind of localize your OCTB scan over the area of imaging interest. So what are the future applications of wide field imaging? So we anticipate this might be able to have us rethink our overall classifications of things like diabetic retinopathy, retinal vascular occlusion. We talked about applications in screening. AI and machine learning could also be a good candidate for ultra-wide field imaging. Research, on clinical trial biomarkers, we heard Dr. Talcott talk to us about, maybe leakage is something that we can look for some sort of response to treatment in ultra-wide field imaging. And I'm really interested in the relationship between the macula and the peripheral retina. We don't know exactly what the relationship is, but I think imaging platforms like the Silverstone can help us understand that. Thank you.
Questions at the end again, and our next speaker is going to be Dr. Fauzi on an update on the white dot syndromes.
All right, thank you guys for having me tonight, and thank you for staying late, everyone. So I want to talk about the white dots because I think when I was a fellow, when I was a resident, these were some of the hardest patients to diagnose. And I've thought a lot about this, and I think the reason why the white dots are so difficult is because the diagnosis and all the papers that I read when I was a resident, was based on color photography. So basically, clinicians like Lee Jampel and Don Gass were able to look at these and tell what level the lesion is and give it a name based on just clinical exam. As we're getting into our sort of generation, we're using OCT a lot more. And it's very hard for us to see these lesions. So they're not really white, they're more gray, and they're not easy to see on clinical exam. And if you think about the names, some of the names are very confusing because multifocal choroiditis barely has any choroiditis, and MUDES has more spots than dots. So these names actually confuse us more than help us. But I think if you just had one machine to use, one image to order on these patients, I would choose an OCT because it's less ambiguous. You see exactly where the lesion is, and they don't look similar at all. And they're completely different, especially if you have follow-ups and you see where the lesion started. These lesions are easily told apart by OCT. So that's the gist of this. Now you have to sort of redefine these diseases by OCT, and I think the IOSG group is going to come out with a whole spectrum of disease in AJO this year using multimodal imaging. So we started with AMN because that's my foray into white dots. That was a patient I saw at the county. She came in, acute loss of vision in both eyes, had these big scotomas. She had drank a whole bottle of NyQuil the night before and woke up with these scotomas. And she came to the county. We didn't have an OCT in the county. The clinical exam was difficult. This is what I saw. I'd read about it. I said, let's bring her over to the clinic at Doheny and get an OCT. And the first thing you see with the OCT is the near infrared. You get the added benefit of this beautiful sort of butterfly lesion that shows up very nicely. So that was the first sort of, now you see the wedge-shaped lesions pointing to the fovea, where in color photography they're almost invisible. And then we started getting OCT, and this is where the lesion first starts. It starts in the in the outer plexiform, Henle nerve fiber layer, and notice that the OCT, the outer segments, are completely normal at this stage. A few days later, it dives down to the photoreceptors. The Henle nerve fiber layer lesion disappears and the photoreceptors are wiped out. And if you look at the infrared lesion, it becomes darker. And then they resolve. They get recovery, the photoreceptors start to grow back, and the scotoma improves. And over time, you can get healing and not complete recovery of the photoreceptors, but almost. So not as good recovery to the photoreceptors as in mutes, for example. And that was sort of our first paper. Based on where the lesion starts, I sort of came up with this idea that something has to happen at that level for the lesion to start there and dive down to the photoreceptors. And that was sort of our hypothesis. Something happened at the deep capillary network. It wasn't until we got the OCT angiogram that we could prove this. And then PAM came about, and so we wanted to sort of look at the two lesions. So we hypothesized that one is at the deep in AMN, so the flow is sort of lost at the deep capillaries, whereas in PAM, the flow in the middle capillaries is lost, and then you get sort of the different levels of lesions. So now I'll transition to another white dot. This is another 30-year-old with decreased vision, just unilaterally. And here, the clue is in the fovea. So a lot of times the white dots are hard to see, but the foveal granularity is a lot easier. And the nice thing about the foveal granularity is it could stay forever. So even after the original white lesions go away, if you see this, that's sort of a clue that this patient may have had an episode of this disease in the past. And so if you look at the autofluorescence, you see a lot more spots than you saw clinically. The fluorescein, is not very helpful because these lesions aren't always there, these wreath-like hyperfluorescence. And on ICG, you see a lot more spots, but you have to wait till 30 minutes on the ICG to see the spots. So this is sort of, and that's the MUDS, the multiple evanescent white dot syndrome described by Lee Jampel in the 80s. But I contend that if you look at the OCT, it really reveals the lesion. So you have the dots, which are these volcano-like eruptions at the level of the photoreceptors, and then the spots, which are zones of photoreceptor loss that cause the bigger sort of lesions on autofluorescence. And then when you look at the EMPHAS OCT at the level of the photoreceptors, you see all the spots, the big ones and the little dots, and then over time, everything resolves. The photoreceptors come back to completely normal, vision improves, usually without treatment. And like I said, the foveal granularity can be your sort of permanent mark of a patient having had that episode. This is another white dot. This is now a grayish lesion in the fovea with acute decline in vision. And again, if you had one exam to get, the OCT gives it away. You have this sort of eruption between the RPE and Brooks membrane, hyperreflective lesion there, and then it erupts into the outer retina, and that's your sort of PIC multifocal spectrum. And depending on where the lesions are and how many they are, you either call them PIC or multifocal, but this is sort of the sine qua non, and then you can have around it some involvement of the outer retina, maybe a little bit fluid, but if you scan through the original lesion, what you see is that sort of hyperreflectivity between Brooks and the RPE. And so the risk of CNV is high in these eyes, and that's why we talked about OCT angiography. Sometimes they get zones of photoreceptor loss around the central lesion, sort of an autoimmune reaction. And in those patients, we find that steroids or immunosuppression may be helpful. So here's another white dot. This one, there's a lot more spots, hypofluorescent on fluorescein, and then with late staining. And you could see that some lesions have pigmentation in them. With ICG, they're hypofluorescent, even from the earliest ICG frames. So this is now AMPI. And so here the clue is this block of hyperreflectivity of the outer retina. And if you look below each block of hyperreflectivity, there's a sort of a absence of the signal of the choriocapillaris. And the hypothesis here is the lesion starts in the choriocapillaris, acute ischemia, with this sort of ischemic lesion in the entire outer retina, including the RPE. And you could compare the area with the lesion, with the normal choroid in between. Every one of those will have that sort of block-like lesion. And then with time, the lesions resolve, the retina recovers, and there's a lot of remodeling. Remodeling in the choroid and remodeling in the outer retina. And that was one of the most amazing cases. I saw this patient with descent of the external limiting membrane, not a single photoreceptor in the fovea, hyperpigmentation of the RPE. And then if you're patient and you follow them, over time the photoreceptors recover amazingly. And so there's something about this sort of acute, very transient ischemia of the choriocapillaris that is not permanent enough to cause complete loss. And so we've sort of documented this in some of our patients, and we saw that consistently the photoreceptors come back. It's just you have to wait a long time, and the patients are very unhappy and complaining and sort of symptomatic, and many people would treat them with steroids just to enhance this process, but we don't have any evidence that it helps. Again, the recovery and the remodeling of the choriocapillaris is very dramatic. You could see the areas in red, those are the remodeled choriocapillaris where the lesion started, and the areas around them are the normal choriocapillaris. I want to talk about this last placoid lesion, not because it's common, but because it explains something about these diseases. So this is another placoid that Lee described in the early 2000s. And then when I was there in 2012, we got a series of them, basically intense hypofluorescence on ICG, bilateral symmetric white lesions in the macula acutely, and sometimes they present even with CNV in that white lesion. And he named this persistent placoid maculopathy because the hypofluorescence lasts for a very long time. So from that case, I learned something. So if you look in the nasal area, originally there was no lesion there, and then in 4 weeks she had whitening there. And if we look in the choroid, in the original, there's normal choroid. When it became white, the choroid was completely opacified, all the way down to the deep choroid. So that's the lesion that made me believe this disease starts in the choroid. The deeper in the choroid, the worse the outcome. So these patients don't get complete recovery, and instead they get wipeout of the photoreceptors. So I think all the placoids have some level of choroidal involvement. The deeper and the more intense, the more severe the loss. So in AMPI, there's just choriocapillaris, acute and transient. In PPM, there's severe and sort of deeper involvement. And then relentless is sort of a disease that we don't see often, but the episodes keep recurring. And so, in summary, look at the OCT. If there's photoreceptor involvement only and it's transient, recovers, that's MUDES. If it's between Brooks and the RPE, it's PIC multifocal. AMN and PAM are ischemic, so we don't really count them as white dots. And AMPI is this block of choroid outer retinal involvement. Hopefully this helps you sort of tell them apart a little better than when I was a resident. Thank you for having me.
Okay, I'm going to be moving the last talk. And then after this, we have our fellow session, which will be over in the Shanghai room. So all residents, fellows, trainees, please come over to that. I think there's food, beer, and wine over there as well. So we'll be talking about OCT angiography and retinal vasculitis. My financial disclosures are listed, but none are relevant. So we've heard already today that there are a number of advantages and disadvantages of OCTA. There's no dye injection. It visualizes flow in the different areas of the retina separately, and it gives you really high resolution and high contrast imaging of the microvasculature. But we don't really get any leakage information. The quantitative tools aren't the best, and there's a lot of different artifacts. But I really want to focus on maybe we don't necessarily know enough about that leakage information, and can we really dive into and understand, can we see activity in retinal vasculitis just on OCT and OCTA? So looking back at the literature, there's been multiple studies that have looked at OCTA findings in retinal vasculitis, but for the most part, they have focused on the on-phos parameters such as non-perfusion and capillary density, with really no information on inflammation of the blood vessels themselves. This is a paper that looked at overall vascular changes. They did see that there were multiple eyes that had non-perfusion, hyperperfusion, and you saw that in those eyes that were active. And then you see peripheral capillary leakage, and that correlates with perivascular and macular and generalized thickening. But they also looked at the retinal thickness maps and saw that when eyes were active, the retina around the blood vessels was thicker and in multiple areas was thicker. Here's another study that did the same thing, and they looked at what happens pre and post treatment, and you see in the top in image B that thickness map, then when you go and treat the patient down in image G, it gets better, and that corresponds to improvement in the fluorescein leakage. But what's really happening in those areas? Can we really dive in and look at the OCT and the OCTA in those areas to understand what's happening? So first, what we did is we aligned our FA images with the OCT on FOS images, and then evaluated the corresponding OCT B-scan images in the red all the way on the right were areas that showed leakage on the fluorescein. And when we go in and actually look at what's happening on the B-scans at the sites of vasculitis, we see a number of things. We see retinal thickening, and the thickening is interestingly more in the vertical direction, so into the vitreous. And we see hyper and hyporeflective changes around the blood vessels. We interestingly can often see an expansion of the flow signal, so there's more flow in those vessels corresponding to the areas of active inflammation. And then we also see the vessels are pushing down the outer nuclear layer. When we look at a couple different patients when they're active versus when they're inactive, and now the yellow line is corresponding to where we're actually scanning across, and we're seeing some of those similar changes. And if you look at each of those, the two arrows on the right and the left of the image, we can see the expansion of the flow signal and how it changes in the bottom image in those corresponding areas as you treat this patient when they become inactive. And then it's more in the veins because this is more venous leakage than it is arterial leakage, and we don't really see a change significantly in the arterial signal. When we look at eyes that are active, again, this is another eye that was active and then less active. Interestingly here, this is the opposite. If we look at the arrowhead, the flow signal actually increases as we treat the patient in that same location, and this is really interesting. And I think that there are a variety of changes that we're seeing. We're seeing these hyperreflectivity around the blood vessels when these eyes are active, and we don't really know what that represents. Is it actually infiltration of blood cells? Is it fluid leaking out? We don't really know for sure, but there's a number of changes there. And as you take an eye that's active at that arrow and then you treat them and they're less active, we can actually see that the perivascular change goes away and the flow signal remains, and sometimes the flow signal increases and sometimes it decreases. Now this is where it gets really interesting. These are eyes that don't really show a ton of leakage when they're active, but when you look at these blood vessels, you can actually see those same changes. These perivascular changes are occurring, and with treatment, those changes are actually going away. And so maybe some of these patients are bitterly symptomatic. We look at their FA, we tell them, you're fine, you look okay, we don't really see much of anything. But when you actually treat them, those changes go away and the patients feel better. And so maybe we're actually missing some of the active inflammation in these eyes with retinal vasculitis because it's so subtle and it doesn't quite show up on the FA yet. And so it's another patient similar. You can see some vascular tortuosity. We don't really see much leakage on the FA, but this is another patient that gets treated because they're symptomatic. And as they get treated, even though the FAs look fairly similar in the active versus the inactive phase, the OCT changes are pretty significant, and that area of hyperreflectivity around the vessels and the changes of the vessels thickening in the vertical direction actually get better. Another patient where we're looking at those changes, and we can see that as the patient gets treated, the overall hyperreflectivity around the blood vessels is improving, and it improves, and as it improves, you can see these changes go away. And so this is really interesting. Now, they don't always go away in some of these eyes. So in this patient, for example, that pushing up of the retinal thickness in that area, even though they become inactive, that change doesn't really go away. Now, what does improve is that hyperreflectivity around the blood vessel goes away over time. And so we can also see Something else, we can have some patients that actually have a hyporeflective change around the blood vessel in addition to the hyperreflectivity. And then as they get treated, again, those changes do get better, and you lose both that hyper and the hyporeflective change around the edges of the blood vessel. And so maybe there is actually something there. And it's often because most of these diseases have mostly venous involvement, it's most often seen around the blood vessels. And we see that that flow signal, when they are active, can actually be either increased or decreased. And so maybe if we really dive into this and figure out a way to look at this in a quantitative manner, we'd be able to look at that and actually say when someone is active or inactive just based on OCT and OCTA alone. And so this is something that we looked at, and we did this quantitatively, and I'm going to kind of move on to this area as where we measured at the site of inflamed blood vessels. And we looked at a number of different things. We looked at the overall retinal thickness. We looked at changes in the flow signal in both the horizontal and the vertical dimension. We looked at retinal thickness elevation compared to the ONL thinning, and we developed a ratio of looking at the retinal thickness elevation ratio to the ONL thinning ratio. And we see some very interesting things. This is in 75 vessel points of 20 patients who had both an FA and an OCTA image on the same day, and we measured and compared them between the active phase and the inactive phase. So in the same patient, as you treat them and they go from being active to inactive, you see that the retinal thickness comes down. You see that that vertical flow signal diameter decreases significantly, but not much, if any, change on the horizontal side, although there is some, but it didn't reach significance, probably because we didn't have enough patients. The retinal elevation ratio also actually comes down, and the ONL thinning ratio actually goes up, so that pushing down into the ONL improves, but almost all of that is for the veins, very, very little in the arteries. Now, it's probably a little bit because most of these diseases that we imaged were mostly venous involvement with very little arterial involvement. But when you do a logistic regression and you start to look at what's actually relevant, you see something interesting. So that retinal thickness change wasn't that significant, but the perivascular changes were, and the ONL thinning and the retinal elevation were also pretty significant in terms of how much of a likelihood there was of disease activity. So can OCTA detect disease activity? Maybe. And I think it's more of looking qualitatively at the OCT-B scans, understanding what's happening around those blood vessels, and then from there, can we then develop a model of assessing vasculitis activity and how they respond to treatment? So I think we still need a lot more work in this area. This work was done by one of our research fellows, Dr. Yuka Mizuna, who's from Japan, and a bunch of other people in our lab who helped with this analysis, but this was fantastic work by her, and thank you.
Questions for the session before we close up?
Sumi, that is beautiful. So I saw a sort of a presentation by Giovanni Staurenghi. He's using that high-res OCT, and he's showing space, like perivascular space on these images, and I think that's sort of what you're trying to show, but I think the sort of elevation of the vessels is pretty remarkable.
And it's not just elevation, they're actually coming down too. Yeah. So they're actually going both up and down is the interesting
Maybe
thing.
It's the sheath around the perivascular space.
There's perivascular thickening. There's definitely something happening, and I think what we need to dive into more, and we need a lot more patients to understand this, is what's the difference between the hyper and the hyporeflective, and I think high-res OCT will help with that. But there's definitely something there, and we've not really paid much attention to it in these eyes over time.
Mani, do you remember in Giovanni, Sunil and I were just talking about that, when he showed that, if it was vein and artery or if it was just vein? Because I wonder if there's something also about that around the hyporeflective side too. I can't remember for sure.
I just remember he was showing these sort of train tracks next to the
and the
blood
fluid
vessels.
cuffs around it.
Yeah.
Take us home, sir.
All right, so we want to thank all of our exhibitors and our sponsors. would not be possible without them, so we really appreciate all of their support and want to thank everyone for sticking around. And for any of the trainees, please stay for the panel that's going to happen in the Shanghai room right next door.
Or non-trainees, they can come and get advice from Sumit Sharma. That's always a good thing.
That's right. And then this is how you can claim CME credit. You can get the QR code, and from here you can go ahead and click through and claim your CME credit. You need to complete the pre-test and the post-test, and you'll be able to print your certificate from there. So we'll leave that up, and we'll put that back there. Great. So thank you.